it up right now.
So who's going to take roll, you or John?
I believe John has the list for roll call, sir.
Very good.
Sir, I believe we are live on YouTube.
Very good. We'd like to welcome everybody who is joining us on YouTube and those who are going to be participating in our meeting today. This is the Joint Subcommittee on Mental Health and Substance Abuse, comprised of House and Senate members from the Labor and Health Committee, along with Senate and House members of the Joint Appropriations Committee. My name's Lloyd Larson. I'm from Lander. I'll be co-chairing with Senator Dave Kinski from Sheridan. And with that said, before we take roll, John, we'd like to recognize John Brody and Elizabeth Martineau from LSO, who will be staffing for us today. We'd just like to make some comments a little bit. For the intent of this meeting today is really to make sure that the members from the Appropriations Committee are caught up with the understanding on funding, sources of funding, population served by our mental health providers in the state, and then to ask questions concerning what role the state has in providing mental health moving forward. I think we want to be a little bit careful on, I think everybody looking at our revenue picture understands that there will be cuts in budgets in the foreseeable future. I don't know that that's really part of today's discussion. That may come up in following discussions, but we're just really trying to understand how the funding comes to those providers and the statutes governing mental health centers at this time. So with that, John, could we go ahead and take the roll?
Yes, Mr. Chairman.
Representative?
Chairman Kinski.
Yeah, I was wondering if I might just make a couple notes.
If you would, please.
This is an unusual subcommittee, being appropriations and mental health. And I appreciate everything that Labor and Health Committee has done over the years. Part of why we're all thrown together into the basket is, and Sue, you've been on appropriations, you know what it's like. It's you see every single department come in front of you, and you're about a mile wide and a half-inch deep in terms of your subject matter expertise. And when it comes to the Department of Health, mental health, and substance abuse budgets, we've had a lot of free-ranging discussions on appropriations, none of which have really led to much in the way of conclusions. And I think part of that is we needed to have the actual subject matter experts at the table as well before appropriations does whatever it is that appropriations does, and so that we can do no harm, which is the first element of the Hippocratic Oath, right? Is first do no harm. And for that, we have to move forward in a meaningful, informed way. And I know I've got a lot of questions about mental health, substance abuse, and the funding and the models, and concerns about where we cut and whether that might actually engender greater rather than less expense. So I look forward to learning from you folks as we move forward in this process. And I appreciate your time and expertise. I know we're going to be plowing a lot of the ground that you folks have already plowed. So I appreciate your patience with the balance of the group and sharing of your subject matter expertise. Thank you, Mr. Chairman.
Thank you, Chairman Kinski. John, let's go ahead and take roll, please.
All right. Senator Bouchard.
Here.
Senator Garou.
Here.
Senator Schuler.
Here.
Representative Barlow.
Here.
Representative Olson.
Here.
Representative Wilson.
Here.
Co-Chairman Kinski.
Here.
Co-Chairman Larson.
Here.
We have a quorum.
Thank you, John. So we'll move into the review of community mental health centers. We've asked the Department of Health. I think we've got Stephen Johansson waiting in line, and just again, a comment for those who may be coming on and speaking and getting ready for public comment. As we start winding, we'll try and let you know there's a little bit of delay as you watch on YouTube to the actual Zoom meeting that we're participating in. And so we may experience a little bit of delay. It's been our experience, and we'll try and make that as short as possible. So I think, is Stefan with us?
Mr. Chairman, good morning. Can you hear me?
I can. Stefan, if you would kind of lead us off here at the beginning of this and on our funding sources, funding formulas. And then my question, I guess, to you, Stefan, would be, would you like us to ask questions as we move along, or would you like us to wait till you've completed your presentation?
Mr. Chairman, that's a good question. I'll certainly leave that to the deference of the committee. I think a lot of this, as I heard Senator Kinski mentioning before, might be a little bit of a review for the folks from our Joint Labor Health Committee. But it might be more efficient, Mr. Chairman, if I go through the presentation somewhat quickly and take questions at the end. But I'm more than happy if there's something that really doesn't make sense or isn't resonating, or you need more detail to answer questions as we go. But I think with the slide deck that I sent to the committee members, I don't think I can share my screen, but it looked somewhat like this. That you might have in your materials, probably less than an hour to get through that information, and then happy to take questions at the end. But I'll leave that up to you and the committee members, Mr. Chairman.
So committee, if we can, we'll allow Stefan to make his presentations, but if there's something that you just really feel that you need to ask a question on, raise your hand, we'll call on you. Senator Kinski, if you'd kind of keep, if I miss somebody raising their hand, let me know, and we'll interrupt Stefan as we move along. So let's go to your slide presentation on the mental health and substance abuse overview, Stefan.
Mr.
Thank you, Mr.
Chairman, Mr. Co-Chairman, are we now on the one that says mental health substance abuse overview?
That's
There we go.
Yep, yep.
Oh, he did share
Online.
the screen. I thought he couldn't do that. Thank you.
I find they can do about anything.
Mr. Chairman, I'm trying to figure out how to make this full screen. We'll see if the AP get the banana here.
No, you're good.
Okay, well, we can leave it as is, if you can see the screen. Again, members of the committee, appreciate the opportunity to testify before you this morning. This is a topic that for the Department of Health and many of you, both on the joint labor and the joint appropriations side, that we've worked on in different contexts over a number of years, including just in general, but also in the Title 25 context, the Title VII forensic behavioral health context, as well as various issues with funding, Department of Corrections, priority populations. So I think this is a good opportunity with a group like this to review a little bit of background on behavioral health in Wyoming, not specific at first to the community mental health and substance abuse system, but start off just on the agenda here with a very quick overview of behavioral health funding across a couple of different agencies, both ours, the Department of Health, Department of Family Services, Department of Education, and some private market estimates that we've been able to produce using our multi-payer claims database just in the past a couple months or so. So just a little bit of level setting, Mr. Chairman, on what the broader context of behavioral health in Wyoming from various sources looks like. And then we'll dive into an overview of the community mental health and substance abuse system, both with an overview of the system, a description of some of the priority populations, both on the federal side as well as through our state contracts with providers, an overview and summary of the funding for community mental health and substance abuse, and then per the committee's request on the agenda, a little bit of an overview and I would say a a review of the gatekeeping statutes that are in Title 25. And I know several of you on this committee worked with us and with another legislative subcommittee years ago to kind of refine some of the statutes in Title 25, and we'll focus a little bit on what gatekeeping is, at least from my perspective in the department, what it was intended to do, and kind of where we are with Title 25 gatekeeping. So moving on and try to be expeditious with this overview, Mr. Chairman, but like I said, feel free to ask questions either now or at the end. This table on slide 3, we tried to put together a kind of a summary of the estimated annual expenditures of behavioral health. And again, I want to stress that this is not just to the community mental health and substance abuse system. This includes Medicaid reimbursements for behavioral health services to other providers, to hospitals, to clinics that are not necessarily community mental health and substance abuse centers. And on this table, you can also see we included Department of Family Services expenditures for behavioral health related services, as well as Department of Education expenditures when they essentially for children on IEPs or children who are in residential treatment centers or BOCES. There's a Department of Education spending that is behavioral health related. So we worked with those two agencies to, over the years, working well together to estimate those expenditures as well. And then, like I mentioned, Mr. Chairman, on the private insurance and the Medicare side, we were able, for the Joint Labor Committee a couple of weeks ago, to produce some estimates of what that spending looks like. And again, on the private insurance side, these are, the reason you see the tilde there is these are estimates based on a model that was created with our multi-payer claims database, as well as census data for the state of Wyoming to estimate out of those that are in the census potentially responding with some sort of need like this or fitting a demographic profile, I should say. We combine that with the multi-payer claims database, which is primarily the state employee health insurance plan. So we can see expenditures for behavioral health in that plan. And essentially, it's a big assumption, and this is exactly what it is an assumption. If we assume that other insurance plans like Blue Cross Blue Shield or other privately insured plans are similar to the state plan, which again, it's an assumption, we can back into a little bit of an annual estimate on what the broader population, insured population is quote unquote spending or being reimbursed for when it comes to behavioral health. So all in all, with all of these sources, we estimate around 272 to just over $300 million a year in behavioral health related expenditures. A relatively large line item, but when you have Department of Health, especially when you include Medicaid, which on an annual basis, about 80,000 members in Wyoming Medicaid, on a monthly basis, a little bit less, somewhere around 60,000 because of the churn. It is a lot of people, and in the privately insured market, also, a lot of people, far more so than what we see in just, one of the areas of behavioral health in the department, which is the community mental health and substance abuse program. Mr. Chairman, moving on to slide 4, we divided just the Department of Health behavioral health program, similar to what you saw on the previous slide, but with a little bit more detail just for the department's areas. And that's across really 3 areas, BHD, which stands for Behavioral Health Division, then your Public Health Division, and your Healthcare Financing Division, which includes Medicaid. So the first 3 rows on this table, you can see really is what we'll talk about mostly, and really the first line is what we'll talk about mostly today. And that's our community mental health and substance abuse unit, treatment unit. Those are the contracts that our behavioral health division manages with about 18 community mental health and substance abuse centers. But also in the behavioral health division, we have the court supervised treatment program, also affectionately known as the drug court program, which represents about $3.4 million in expenditures. And last but certainly not least, in behavioral health, the state hospital, which provides services for both civilly committed patients on the Title 25 side, as well as outpatient and inpatient forensic evaluation services on what we call the Title VII side, or the criminal justice services unit of the state hospital. The reason I bring all of these up in this context is we've tried over the years, both in conjunction with the Facilities Task Force, as well as the Joint Labor Committee, the Title 25 Subcommittee, to really see this behavioral health system, especially on the state-funded side, as a continuum. So you have your community services, which can and often do act as an alternative or a preventive measure for higher levels of care, like a psychiatric hospital, like a correction setting, whatever the case may be. Then you have your sort of higher levels of care, even up to your institutions like the state hospital, or on the adolescent side, your psychiatric residential treatment facilities, or PRTFs. And then again, upon discharge from a setting like that, kind of as a mirror, you have the community continuum on the back end. And so in theory, we've tried to see this as kind of a large system, even though they're somewhat disparate, of behavioral health services that can be provided along many different levels of care. Just really quickly, Mr. Chairman, on the public health side, that's the division that houses our prevention programs, which go through county contracts with county governments for substance abuse, tobacco, and suicide prevention. And that accounts for about $8 million of expenditures, but broken out at about 50-50 state general fund and other funds, here shown as tobacco settlement funds. And finally, Mr. Chairman, on the healthcare financing side, that's generally the big elephant in the room. On the Medicaid side, we have payments for those that are covered or enrolled in Medicaid for behavioral health related services, approximately a little bit over $40 million a year when we carve out that claims data. I believe, and I'll double check with my folks, that does not include pharmacy spending. These are just for mental health and substance abuse service related claims. And again, as members of the committee likely know, those Medicaid expenditures are generally matched at 50-50 between the state and the federal government. Also in healthcare financing, we have what's called the Care Management Entity, or the CME, and that's really wraparound services for Medicaid children who meet a certain level of need with mental health or behavioral health. So you might have heard it in the past referred to as the Children's Mental Health Waiver. This is essentially that program, but basically a wraparound service, case management, care coordination for kids at a little bit higher level of need, higher level of care. And the real intent there is to prevent the need for PRTF level of care, or when kids are coming out of higher levels of care, to ensure they receive the services in the community that keep them and their families stable. And then finally, Mr. Chairman, psychiatric residential treatment, or what we call PRTF, that's another line item for Medicaid. That's basically residential psychiatric treatment for those kids and adolescents. This, you might remember that it involves both just Medicaid kids on a physician order, but also folks who are in the kids who are in the DFS system in the custody of the Department of Family Services. They are automatically eligible for Wyoming Medicaid by nature of being in that system, and some kids do require in that system a PRTF level of care, in which Medicaid would be the primary payer for that. So all in all, with the Department of Health now specifically, we estimate around $160 million of annual expenditures. And these are based largely on the most recent complete fiscal year, so fiscal year 19, and primarily located in the 2019-2020 Department of Health budget. Just really quick, I won't go through this in great detail, but just wanted to give the committee a snapshot, and the joint labor folks have seen this a number of times, so appreciate your patience while we do a little bit of review. On the DFS side, this table shows kind of your mental health and substance abuse related expenditures for certain services like counseling, day treatment, mentoring, or outpatient substance abuse, and compares that to kind of the total services for the DFS side of the budget when it comes to mental health and other services. But what I want to point out on the DFS side, Mr. Chairman, on slide number 6, is what I think more people will be more familiar with, which is more your kind of residential or facility-based care for DFS. So DFS does have a significant line item of expenditures for kids who are placed in group homes, as well as kids who are placed in RTC, which stands for Residential Treatment Center, or BOCES, kind of an alternative educational setting. And you can see those expenditures there for those kids. And then on the last two rows, you can see the fixed cost estimates or expenditures, I should say, for the Wyoming Boys School and the Wyoming Girls School, which are direct care facilities operated by Department of Family Services. So again, Mr. Chairman, just background information here to give kind of a wider context of the behavioral health landscape before we dive into the community mental health and substance abuse programs. We did include working with the Department of Education, kind of the educational behavioral health related costs, for lack of a better term. And you can see across those same settings like RTCs, BOCES, and PRTFs, around $6 to $7 million, depending on the fiscal year, of Department of Education expenditures related to this area. And these figures were provided by the department. Mr. Chairman, like I mentioned in the agenda, we'll give you a little bit of some more detail on our estimates of privately insured mental health and substance abuse spending, again, for the purpose of really level setting with this committee on some more deep background, for lack of a better term, on what the system really looks like across the state. We estimate for employer-sponsored or for directly purchased insurance about 340,000 covered lives, and that essentially comes from the census, what's known as the ACS, or the American Community Survey. And then, like I said, we use the Wyoming multi-payer claims database to estimate a per member per month cost or spending on behavioral health services, broken out by age and broken out by sex. Like I mentioned, in this estimate, in this model, we assume that privately insured spending in Wyoming is similar to EGI, which is the state employee plan called Employees Group Insurance. And we define behavioral health spending as having a behavioral health primary diagnosis and a hospital or behavioral health provider taxonomy code. Again, there's multiple ways to skin this cat. This is work that happened here in the director's office just a couple of months ago to try to get some estimates for the legislature on what this likely looks like in the private sector. We will give a little bit of a caveat that claims data, even from our privately insured plans and working with the multi-payer claims database, is generally lower quality claims data than Medicaid. So a lot of missing fields, taxonomy codes, et cetera. So we only point that out because it is a luxury to have Medicaid data across all of our states. But what we are able to view in more granular fashion in Wyoming is generally higher quality than what you see in privately insured plans. So again, just want to give the committee a few caveats that we made some assumptions here, but I tried to back in a conservative estimate of what mental health and substance abuse spending looks like in the private market.
Okay, Stephen.
Yes, sir.
Why don't we call time out right here on this first section and go back to the committee and ask if anybody has any question on those first 8 slides that maybe we can address so that we don't get too lost as we move forward. Committee, any questions?
I have lots of questions, but I'd rather keep moving. I don't want to, I'd slow it down with my questions.
So there's just a couple that I need to, if I may, get cleared. Back on slide 3, Stephen, where it talks about the Department of Education spending. Is that by agency, or is that the district sped funds, or is that a combination of both?
Mr. Chairman, that's a good question, and I'll give you an initial answer, but I will confirm with the Department of Ed. I believe that is just the Wyoming Department of Education's expenditures, but I need to confirm if that includes other spending at the local level. But I'll have to follow up with the department on that and make sure that we get that clarification. If you would. And then on that next slide on 4, that wraparound services, that's the one we have a contract for statewide that's providing those services. Is that correct? That Magellan contract? Mr. Chairman, that's right. And that is, like is shown here on the table, That's a contract between the Healthcare Financing Division and that vendor.
Then on your DFS slide on page 6 are the group homes, so the boys' school and girls' school, that's all general funds. Is the same true with group homes and RTCs?
Mr. Chairman, another good question. In terms of the funding source breakout, I don't want to shoot my mouth off saying this is all general fund. I actually don't know. I think largely it is, but I'll confirm that with DFS and get back to the committee. I don't have the funding breakout in front of me, but we can certainly get that.
Okay, thank you. Anybody else? Okay, Stefan, thank you. Oh, whoa, sorry. Senator Guru.
Thanks, Stefan. And staying on slide 6, just a breakout, you don't have to do it now, but just a breakout of how many people were serving in each of those group home, both seats, the boys' school, the girls' school, just breakout numbers of how many people were serving in each.
Mr. Chairman, Senator Guru, happy to follow up with our friends at DFS and get that breakout.
Chairman Wilson, please.
Thank you, Mr. Chairman. I was looking at slide 4 as well. And Stefan, so I see that I was trying to run some numbers myself on, the amount that we're spending on community type services and then the amount on inpatient services. Then I see the Medicaid is, and I thought, well, maybe that's evenly divided or not. But just to clarify for everyone, the recipients of those or the patients for whom those Medicaid dollars are paid out would typically be either children. I mean, when I think of the categories of people who receive Medicaid, children, pregnant women, seniors, and people with, who've been determined to be disabled. So most of those claims would be either for children or perhaps senior citizens, or if they were adults between 19 and 64, they would pretty much have to be either people with developmental disabilities or people whose mental illness was severe enough for them to be on Medicare as well with a disability, right? I mean, just to make sure, because we tend to think of, there's certainly a lot of people between 19 and 64 who might have mental illness, but they are not going to probably fall into that category. Is that correct?
Mr. Chairman, Representative Wilson, yes, and it's a good point. So just as a reminder to the committee on that Medicaid line item, to be eligible for Medicaid in Wyoming is not just being low income. In fact, just being low income in Wyoming does not qualify you or make you potentially eligible for Medicaid. You have to meet, as Representative Wilson was alluding to, what we call a categorical eligibility criteria. And Madam Chair, you mentioned one of them or several of them, but yes, it's essentially the aged, blind, disabled folks who might be in one of our waiver categories, developmentally disabled, and like you mentioned, long-term care populations that might be dually eligible for Medicare and Medicaid. But I'll mention that on the dual side, like you mentioned, being eligible for Medicare would typically be the primary insurer, but we run into some issues with Medicare where behavioral health isn't covered the same way that it is on the Medicaid side. So yes, to answer your question more simply, even though I've droned on and on, you have to meet a categorical eligibility criteria to be part of that Medicaid line item. So again, kids, aged, blind, disabled, and in certain other special categories as well. And like I mentioned, that Medicaid population is around, on a rolling monthly basis, around 60,000 eligible or covered members in Medicaid. Now, not all of them require or receive behavioral health services, so all of this is kind of a subset of a subset. But great question, Representative Wilson. That is your 19 to 64-year-olds who are not disabled or don't meet one of those categorical criteria would not fall into that Medicaid category.
Thank you. Follow up, Sister Sue. Representative Barlow.
Thank you, Mr. Chairman. Mr. Chairman and members of the committee, I think it would be helpful, and for staff, and I don't want to put this all in the Department of Health, but it would be helpful comparatively between the different agencies that to have it per member per month or per member per episode, or some kind of a comparator between these different, because I think that at least folks that have been dealing with this file understand that the reimbursement rates are different between the different programs, DFS versus Department of Ed versus, so that'll give us not just an indication of how much money, gross dollars isn't always the most important thing. Sometimes it's how, or the level of dollars per individual treatment and the comparison between those. And I think we're going to see some significant disparity in that. And I think that will help us get to some of the more policy-based things that we can maybe impact. So I guess that'd be my first query is if there's a way to do that. And like I said, I don't want to dump it all on Department of Health, because I think the other agencies certainly should understand more about what's going on too, besides the gross numbers. The second thing that goes along with that is level of care. There has to be a consistency in comparison of level of care. So is it RTC? If it's RTC, it has to be RTC, Department of Education is paying, or what DFS is paying, or what Medicaid is paying, or what potentially general fund or private insurance is paying. There are instances of that. So if we're going to get into these, use these numbers, we got to have some basic for comparison. And I don't know if per member per month is the right way, Mr. Chairman, but something that gives us a baseline to compare between programs and understand cost and the level of service. Thank you, Mr. Chairman.
Thank you. Other questions? So Stefan, before we move on, I would just follow up on Representative Barlow's comments, and that comes down to DFS and Department of Ed. I think they pay different fees to, like, their RTCs and PRTFs. I think they have negotiated fees. We talked a little bit about that in JAC this last year with the Department of Education on having them negotiate fees moving forward. But I think up to this point, that's been the difference, and maybe that can come out in some of this analysis between your agency and the other agencies on costs. So,
Mr. Chairman and Representative Barlow, happy to take a look at that. And like I mentioned at the beginning, there's many different ways to carve out this data. We'll certainly take a look at that to provide additional context to the committee. But you're right. There's different funding sources, different funding models across all of these different lines of service, so to speak. So happy to follow up with some additional information for the committee.
I think we're on slide 9. Oh, follow up, Representative Barlow.
Mr. Chairman, I'm just going to caution us to use how we use the word cost versus how we use what we're talking about. What we're talking about is what we're being charged or what we're paying. We actually probably don't know what the cost is for a lot of these services because we're not actually on a cost-based model like we are for the DD waiver or other things. And so I just throw that out also as something to keep in mind as we're comparing between agencies. It's something that's negotiated or a schedule that was set or et cetera. It's not actually the cost, it's just what we're paying. So I just throw that out as a caution. How we think about the word cost is not the cost of the service, it's what we're paying for it, the charge or the payment. Thank you, Mr. Chairman.
Point well taken. Stefan, I think we're on slide 9.
Thank you, Mr. Chairman. Again, don't have to go into great detail on this, just a visual representation of that private market per member per month estimate for employer-sponsored plans when it comes to behavioral health or mental health substance abuse spending. You can see it's broken out here in the colors by sex, so for females and males. And again, this is an estimate based on a model using the multi-payer claims database and the census data to, again, just try to get a sense of what we see on a per member per month basis in this spending. You can see that largely by age, which is on your horizontal axis, you do see a spike kind of in your adolescents up to your early adults, and then it kind of tapers, goes a little bit tapers off a little bit. So by year here, if you just look at 2019, we do see kind of a spike in the males and females around age 15 to 20 with a per member per month cost there of around $20 to $40. And again, kind of tapering off. And what you can see there is kind of the observed data points in the dots, and then the modeled uncertainty in those shaded lines. Similarly, Mr. Chairman, on slide 10, we break that out based on a few different categories of provider type for these employer-sponsored insurance groups. And this is what gets into what taxonomy codes for those providers we have available in the data to model off of. So what you can see here is about 5 different provider types, moving from top to bottom and left to right. Psychologists and psychiatrists on a per member per month basis, again by gender, as well as licensed clinical social workers or counselors, facility-based per member per month cost, hospital-based per member per month cost, which is largely outpatient services, but in a hospital setting. And then finally, a category called clinic, which really doesn't represent much in terms of modeled per member per month spending. But again, not a whole lot of judgment call or commentary here, just some additional information that we haven't put together before in the department that we kind of have the ability to do through the multi-payer claims database and through some of the statistical modeling that we're able to do here in this office. Just again, situational awareness for the committee, and something that depending on the direction that this committee or others take when it comes to looking at the behavioral health continuum in Wyoming, just an indication of some of the analysis or research that can be produced. Moving on to slide 11, Mr. Chairman, this is again same data with a little bit more detail than you saw before. We do provide the estimate of that annual spending from the private insurance side across those different categories, and you can just see based on the modeled uncertainty kind of our lower and upper bounds of what we estimate based on both the multi-payer claims database, which is basically EGI data, as well as the census data modeled in there to get your demographic estimates, male and female, and other areas that we could potentially model off of too. So we estimate around a little over, like I mentioned before, $60 million in the privately insured market for mental health and substance abuse related spending. And to Representative Barlow's point, it's a great point. On the previous slides where we were talking about state, what I called costs, and he's absolutely right, it's cost to the state, not necessarily the cost of service. It really is a mixed bag on, are contracts or reimbursements cost-based? Sometimes yes, sometimes it's based on history, sometimes it's based on RFP or competitive bidding. It really is a mixed bag. So the point's well taken there that on the Department of Health, especially the Department of Health related spending, when we show those figures, it is cost to the state, either through reimbursements or contracting. Here, again, with the private market, it's really estimated reimbursements that we think might be out there, ranges that might be out there based on what we see in one private insurance plan with the state employees, which is EGI. So just wanted to make that clarification, Mr. Chairman.
Thank you.
In terms of youth residential services, again, just wanted to kind of put this together into a table in terms of the number of beds that we see across these different settings. So going from top to bottom in our PRTFs, which is in the Medicaid space, again, both for DFS kids as well as physician referred kids who are not in the DFS system. We total about 154 in-state beds for PRTFs with 2 providers, those providers being St. Joe's and WBI. And then out-of-state beds that are used on different periodicities, when kids, we don't have the level of care that's needed here, or programming that we don't have in Wyoming, depending on a child or an adolescent's acuity. There's a whole bunch of different reasons why kids might need to be sent out of state. But you can see quite a large network of out-of-state beds on the PRTF side with over 1,600, but only about 11 different providers that are typically accessed in that network for Medicaid kids and PRTFs. The next 3 rows really show on the DFS side your residential treatment centers group homes and crisis beds, again, both on an in-state and an out-of-state basis. But the primary beds for group homes and crisis are all in state here. And then finally, with the Behavioral Health Division, we have residential beds for substance use disorder for adolescents. Again, just kind of a youth summary on this table, 4 in-state beds that are available there with one provider. So not a very on substance use disorder for adolescents, not a high utilization there or a high supply. And again, no commentary on the demand or met need or unmet need here, just a summary for the committee on what we see in bed supply across these settings. On the adult side, Mr. Chairman, all behavioral health division related here for substance abuse and mental health beds. So you can see starting at the top of the table in those first 3 rows, the number of state-funded beds for substance use disorder, as well as substance use transitional beds and what we call social detox beds, which happy to have our behavioral health division folks speak to the difference across these. But these are all different residential beds that are part of our mental health and substance abuse contracts in the community system, which we'll get into in more detail later in this presentation. The bottom 4 rows on this table, Mr. Chairman, are our mental health residential beds. So supervised living, group homes, and crisis stabilization. And you can see what we have in the last 2 columns on this table are the number of state-funded beds, as well as the number of total beds. And the reason we carved it out like this is because even with our community mental health and substance abuse centers, they are private, mostly nonprofit businesses, and the state clients are not the only clients that they serve. So those community centers also serve, those who are privately insured or have other pay sources that aren't just again state of Wyoming clients. So we tried to give you some estimates of the total beds in that system versus what the state is paying for. Mr. Chairman, it looks like Representative Barlow might have a question.
Please, Representative Barlow, I apologize.
Thank you, Mr. Chairman. So it looks like we're going to switch topics a little bit. So at this one, and this goes back to the dollars, census or average census might be an interesting place, as we have X number of providers, and what is the average census anyone, and maybe that's hard to get to, but I think that would be helpful as well, because I think when we're talking about funding beds, we're generally talking about a baseline of funding that whether they're occupied sometimes or not. And so I think that would be helpful in knowing census versus funding level funding level. Thank you, Mr.
Thank you. Other questions? Representative Olson, please.
Yeah, thank you, Mr. Chairman. I'm curious on the topic of beds on page 12, the in-state beds, out-of-state beds, looking at the RTCs and the PRTFs. Can we get a breakdown of the average cost per bed for those out-of-state beds versus the in-state beds? I would imagine they're reimbursed at different rates because of all kinds of various factors.
Mr. Chairman, Representative Olson, short answer is yes, we can take a look at that, especially on the Medicaid side, to look at what our kind of per recipient spending is across those different providers. But you're right, it does vary, and sometimes extraordinary care rates are negotiated with out-of-state providers depending on the acuity of the child. But typically there is kind of a set payment in Medicaid based on an episode. So we'll dig into that. And like I was mentioning to Representative Barlow, these are great questions because there's a lot of ways, especially on the Department of Health side, to carve up this data that might be helpful depending on the context of the discussion. So we'll take a look at that, Representative.
Thank you.
Thank you. And Stefan, along with that, I think once we go to out-of-state beds, then that funding formula changes a little bit between particularly on adolescents, on what the Department of Health pays, the Department of Family Services, and then Department of Education pays. And so maybe you can just kind of refresh our memory on how that works. And and maybe just kind of give us an example on when we may have to adjust that Medicaid rate for an out-of-state facility dependent on the acuity of the recipient.
Mr. Chairman, happy to do that, and that might warrant some follow-up information to the committee. But in general, you're right that when the reimbursement changes on the Medicaid side, it can take a few different lines, so to speak. And we have several cases, even recently, that we've worked on out-of-state placements where certain rates have been negotiated between Medicaid and the Department of Family Services, and the Department of Family Services agreeing to pick up the difference based on the limit that Medicaid has of what it can and can't pay, both by federal rule as well as state appropriation authority. So it can really vary, but happy to put together some examples of what that looks like for the committee, or what it can look like.
Then Stephen, statutorily, when those kids go out of state, and maybe that applies in state too, to a PRTF or an RTC, the responsibility then falls between the three agencies: Department of Health, Family Services, and Education. Isn't that correct? Education then is paying for the education component of it. The Department of Health is paying for medical, and then DFS is paying per diem. Do I have that right, or how does that work?
Mr. Chairman, I think in general that's accurate. It gets, when out-of-state placements are made, especially on the Medicaid side, we run into some issues, as you know, where other states don't define their levels of care the same way that Wyoming does, and vice versa. So, for example, you might have a very similar type of facility in the state of Texas that we would call in Wyoming a PRTF, or a psychiatric residential treatment facility, but the state of Texas, just as an example, might not even define PRTF in their Medicaid plan or regs. And so we run into some issues where based on federal rule, we can't pay for certain levels of care. But yes, generally speaking, for kids in this type of treatment setting or context, the Department of Health and Medicaid, and we're really talking about, in this case, Mr. Chairman, kids who are in the DFS system, who are covered on the health insurance side by Medicaid, and then in these other contexts, like you're mentioning, the educational component is paid for and provided by the Department of Ed, and then other services provided by the Department of Family Services when it comes to kind of the custody in the case of the child. So it is definitely a shared system across those three agencies.
So, any other questions, committee? If I could, I don't see, oh, Sister Sue.
Thank you, Mr. Chairman. One thing going forward that might be helpful, last interim in Labor Committee, we had some report from the department, and I think there was some maps, but I'm looking at this slide on the crisis beds, and I think on slide 13, which I think was more adult, but as far as, so crisis stabilization, I guess in particular, maybe some of the transitional, but we see the number of beds. But I think it would be helpful for us to know the number of providers, but also what the locations of these are, because as we contemplate how we can pay for, oh, there we go. Well, that's good. You see, I probably looked at that earlier. But so what my point then would be with this, that as we move toward maybe some regionalization in healthcare, some things regionalize better than others. Residential care, if a person has to be moved from Rock Springs to Gillette for residential care, that's okay. But obviously in a crisis, it's kind of difficult to take a person from Etna to Douglas or something like that, So I wonder the cost structure for some things like that might be a little bit different, just because you may end up with some more fixed costs in rural areas in order to maintain quick access to crisis beds. I just sort of throwing that in there for our future contemplation. Thank you, Mr. Chairman.
Stefan?
Mr. Chairman, sorry, just taking down some notes. Yeah, Representative Wilson, I think that's a good point. And it goes back to what, like you said, what Representative Barlow was mentioning, and what's not included in this presentation, because it would be a pretty comprehensive undertaking, is when we start to talk about, whether it's the community programs or other types of service provision here, what is the cost that it takes to deliver that service. We have that in certain contexts and don't have it in others. A cost study of residential services could be done. Again, that's not information that I have, and would be a little bit of a project to do. But we do have, Representative Wilson, and the data is a little bit outdated, but we presented it to a subcommittee, and I believe joint labor year before last. We do have the ability to track cost reports and IRS tax filings for certain types of providers. So on hospitals and nursing homes, CMS cost reports are something that we're able to hear through a certain expert that many of you know in my office here is very good at analyzing cost report data from CMS, which is inordinately complex. But for hospitals and nursing homes, we have that ability to kind of show cost structure for those settings. And then across some of your nonprofit settings, like mental health, community mental health centers, developmental preschools, some other provider types, they file, typically nonprofits of a certain size have to file a Form 990 with the IRS, which again gives us some estimates, not the full picture, but some estimates of cost structure, labor cost, essentially what they report to the IRS in terms of their business for tax purposes. So we do have a website. I can shoot that to the committee that we prepared about 18 months ago for again, I believe it was a subcommittee and then the Joint Labor Committee, but it does provide some additional context on cost of these services.
Thank you. Stefan, just a couple of quick questions. Back on slide 11, where you show the cost per service provided hospital psychiatrist, LCSW, we have the cost there, but do we know the number served? So I would assume that the counseling services would probably would perhaps be serving a larger number of individuals, hence representing the larger cost. But if you could clarify that for me. And then, well, let's answer that. And then I have one other quick follow-up question.
Mr. Chairman, don't have a direct answer for you yet. That's something, again, want to clarify on slide 11 here. These are estimates of the privately insured reimbursement, so to speak, based on a model. But that model would likely also have volume attached to it. So we can follow up on that and give estimates of how many potentially how many recipients that would be, again, based on modeled off of our state employee plan, which is about 30,000 covered lives. So it's a good data set. But again, these estimates would assume that other plans look similar to EGI, which is an assumption. It's not necessarily a bad or a good assumption, but just an assumption.
On slide 13, where you talk about your state-funded beds and your total beds, are the total beds, or for example, in the substance use disorder primary, the additional 61 beds, are those by private nonprofits, or I'm trying to figure out like where VOA comes into play there. Are they state funded, or are they how does that work?
Mr. Chairman, it's a good question. So what this represents here in this table is these substance abuse and mental health beds would be located at our community mental health and substance abuse centers. But what the state contract essentially pays for or subsidizes is that penultimate column there, the state-funded beds. And then those same providers, like you mentioned, VOA or Central Wyoming, various providers that have these beds might also have additional supply that they provide and leverage other pay sources for.
Thank you. Okay, I think we're on slide 14.
Yeah, so slide 14 and 15, Mr. Chairman, again, just the same data you've just seen across these different settings, just visualized on a map for in-state. And then on slide 15, we show for the PRTF and the RTC data that you saw before, kind of where that network of out-of-state providers are. And on the PRTF side, it ranges pretty widely, but you can see some density in our surrounding states with Montana, Idaho. Utah is a big location, a bigger location, I should say. I think 3 providers in that area that are accessed frequently for Wyoming children for PRTFs. But also, you can see going down to the southeast of the country, we have some providers that we reimburse for Wyoming kids that are placed out of state. On the RTC side, a little bit less dense, 3 providers in Colorado and 1 up in Montana. Again, on the RTC side, that is, and I don't want to speak for DFS because would be way out over my skis with my level of knowledge on this system. But on the RTC side, again, that's a DFS reimbursed service, and the vast majority, I believe, are provided in state. So, Mr. Chairman, I will stop there, see if there are any questions. The next slide, on slide 16, kind of gets us into our introduction and overview of specifically now the community mental health and substance abuse system, now that we have a little bit of a broader picture when it comes to behavioral health reimbursement service provision statewide.
I'm looking for hands, but see none. Carry on.
Thank you, Mr. Chairman. Slide 16, again, I do my mea culpa for the joint labor folks. This is kind of some deja vu for them just from a couple of weeks ago, seeing this overview. But again, we do believe, depending on the discussions that happen at this committee or others, it is helpful to provide the summary and again, do some level setting on what these different systems look like. So now we're talking, members of the committee, specifically about the community mental health and substance abuse system, which is a state Department of Health funded system of about 18 contracted providers across the state, both mental health and substance abuse providers. Sometimes a provider will provide both mental health and substance abuse services. But what folks might have heard referred to in the past is the state block grants for mental health and substance abuse. So that's essentially what we're talking about now, is the Department of Health and Behavioral Health Division's funding for community providers. So again, much more specific and narrow than what you've seen in the first 14 or 15 slides of this presentation when it comes to all of those systems, Medicaid, DFS, Department of Education, private insurance. Again, the behavioral health landscape is much larger than any one of these components. So just want to be clear that now we're talking about very specific treatment contracts that are funded by the Behavioral Health Division. These contracts, Mr. Chairman, and the funding associated with them.
Stefan?
Yes, sir.
If I may, so I want to make sure that we understand this. So the services provided by the Behavioral Health Division for the community mental health disabled, that's in addition to any Medicaid, private, or other sources that might be available to them.
Mr. Chairman, that's correct. It's a mixed bag, and like I said, the providers, it depends. Some are more dependent on state contracts than others, but certainly provide services to a wider clientele, so to speak, than just the state contracts that are funded here.
Thank you.
Like I mentioned, Mr. Chairman, 18 contracted providers statewide, both mental health and substance abuse services, and the funding in those contracts include base payments and especially on the outpatient side, what we call per hour reimbursement. So these centers offer a mix of outpatient and residential services. As Representative Wilson was referring to earlier, not all of our areas of the state or all of our centers provide the full menu of residential services because, quite frankly, it wouldn't make sense on scale to have all your levels of care provided in a very small or rural or frontier community, for example, because there wouldn't be enough volume or demand to support it. So this mix of outpatient and residential services try to indicate in these last two bullet points in general how these reimbursements happen. So on the outpatient side, services are reimbursed at $87 an hour for the general population and $120 an hour for priority populations, like those you can see indicated here. SMI is a priority population category, or someone with serious mental illness. What I want to clarify, though, Mr. Chairman and members of the committee, is when we say reimbursed, I want to put a caveat on that, because it's not really a fee for service or a reimbursement model in this system. The way these contracts are developed is essentially a service hour target on the outpatient side. So for mental health or for substance abuse, a provider will have a certain amount of hours in a given year or a contract period that the department and the state expects them to provide. Then that service hour quota, for lack of a better term, is multiplied by these figures to kind of get the overall contract amount. Now, recently, the Behavioral Health Division has moved to more of an invoice basis, so kind of a hybrid of the two approaches between straight granting or contracting and fee for service, so that in essence, on a monthly basis, those hours are essentially invoiced for the state clients that are receiving services to determine, the 1/12 payment that's made for that particular month. So again, it's what I want to point out to the committee, though, is just a little bit of nuance that very different from how Medicaid reimburses services on a straight fee for service basis. The client is eligible for Medicaid, the center bills Medicaid for that service, and Medicaid reimburses what's in the fee schedule for that service. This is a little bit different, and historically, going back to the 1970s, has run on more of a grant model with certain performance targets associated in those contracts for both service hour provision, as well as things like wait time and other areas that are measured. The residential services, on the other hand, are funded separately, often through the same contract, but kind of in a different part of the statement of work, and generally, as Representative Barlow mentioned before, on a per bed basis. So the Department of Health will have contract with a certain center, for example, to provide 6 crisis stabilization beds in a certain area of the state, for example. And on those residential services, that ranges from supervised living settings, supported living, like an apartment that might have some services or people that would visit it, all the way up to group homes, and like I mentioned, crisis stabilization. So a variety of different services provided on the residential side, but again, that's not invoiced or reimbursed on a per hour basis. It's largely on a per bed basis.
Stefan, could you just clarify on your outpatient reimbursement of either the 87 or the 120, how does that 87 compare with Medicaid reimbursement? Is that in addition to what they would bill to Medicaid, or are we the payer of last resort sliding fee? Tell me how that works.
Mr. Chairman, good question. So it's interesting because it seems like more and more these days, everyone fights to be the payer of last resort, including the state, Medicaid, private insurance, et cetera. But I will point out that in the contract language for these centers, it is put in the contract that these dollars cannot be used to reimburse when there is another funding source like Medicaid or private insurance. Now, there's some nuance there when it comes to services that might not be covered by an insurance or Medicaid, and then potentially the contracts could be leveraged. But this, Mr. Chairman, in general, and I'll just say that this should be for state clients that are essentially do not have another pay source or another insurance to reimburse for that service.
Thank you.
Mr. Chairman.
Senator Kinski.
Thank you. And this is going back to my introductory remarks, fellow members of the Labor Health Committee. This one slide gets to the heart of a lot of the debate we have on JAC, and I think it bears emphasis. I think self-evident perhaps to you because you spent so much time on it, but we hear on appropriations, well, these mental health centers, one, they're regarded as just another provider, but actually they're almost like a quasi-governmental agency. The state made a decision they were going to use these not-for-profit models instead of providing these services directly. But more importantly, this $87 per hour, people see that. They see that $120 an hour and they say, well, these outfits have no incentive to ever get anybody well. They just create this spinning door, revolving door, and these people just keep coming through the door and then they spit them out and they come back in and they're billing them for $87 or $100. They're making all kinds of money. And it's important to understand, if they get somebody upright and flying straight between the posts and don't see them again, they have that incentive. If that patient keeps coming back and back and back and back and back, they're not getting $87 an hour every time that patient walks back in the door. Stephen said that this is basically a fixed fee contract. They use that $87 as a proxy and then say, here's your per year quota of hours. That's what you get. And if you see that patient 20 times or 2 times, you've got a fixed fee basis. I want to make sure that I'm understanding that correct. Is that correct, Stephen?
Mr. Chairman, Senator Kinski, yeah, I think you make a good point, and I don't want to get too far into the weeds with the history of this, but you're right. It's the state decades ago made a decision to have brick and mortar places like community mental health centers where folks can go kind of on a general access basis and receive subsidized or sliding scale services. Now, as that landscape evolved with different insurances, Medicaid coming online, later to reimburse for these services, the landscape has changed. But you're right, Senator Kinski, that largely this is maintained on kind of a grant, an annual grant basis for certain service provision for a population and a certain number of service hours delivered by the center. To Representative Larson's question before, how do these rates, so to speak, compared to Medicaid? Senator Kinski, you're right. It's not really a rate by certain service where we say, okay, for medication management by a psychiatrist, that's going to be $150 for that hour, whereas a group session from a clinician with 8 or 9 folks in the room, we're going to reimburse that at $9 per person that was in the group per hour. That's what's not done in this system. To your point, Senator Kinski, it really is more of a grant basis and kind of an average fixed per hour type of payment. So again, going back to our discussion on cost structure, from an outside observer, you'd look at this system and say, my goodness, $87 an hour for group, an hour of group services when there's 10 people in the room, that would get very expensive. But it's not really reimbursed on a fee-for-service basis like that. But I will say that there's again, just from the economics perspective, and no judgment call here, there is a certain incentive, so to speak, for what we see across the state on the outpatient side is a lot of group services delivered by clinicians in group settings. And again, no judgment call there, because I know the centers in the system and the providers and the patients certainly benefit from that. But the point here was that it is very different from a private insurance model where you say, okay, here's the fee structure. It's reimbursed when you deliver the service. We'll do some auditing or accounting to make sure you deliver the service. It is just a different system. And like you mentioned, Senator Kinski, historically based on a grant model.
And Mr. Chairman, I think it's also, just if I could, with Stephen, I want to make sure that I'm understanding the underlying rationale here. When the state changed its model and said, rather than under the old system, you had to have a higher licensed clinician sign off on services as necessary, we threw it open to every social worker, every mental health counselor to bill Medicaid direct those people are getting it on a fee-for-service basis. They're getting, whether it's $80 an hour, $90 an hour, or $100 an hour. And the more hours those outside providers see that patient, the more they make, correct? That's a difference between them and the community mental health centers.
Mr. Chairman, Senator Kinski, again, not to be overly frustrating, it is a mixed bag because our community mental health centers also bill Medicaid. But you're right that in recent years, Medicaid did open up the ability for other types of providers to bill Medicaid for services. Now that's set on a fee schedule that a community mental health center or a private clinician that's an enrolled provider and eligible to provide that service would get the same reimbursement, for example, for an hour of counseling. So, you know, a private psychologist, for example, that's enrolled in Medicaid, or a community mental health center that's also enrolled in Medicaid would receive the same reimbursement from Medicaid for that service. But you're right, it's a different funding model than what the state contracts through the Behavioral Health Division offer. Now, we can provide some more information, Senator Kinski, on exactly what was opened up at that time period, and it was legislative, I believe, to make that essentially provider pool wider across the state, where different types of, you know, essentially non-community mental health centers could bill Medicaid for certain types of services. Happy to provide that history.
Senator Schuler, I believe you had a question. Were you done, Senator Kinski?
Yes, Mr. Chairman.
Thank you. Senator Schuler, I think you're up next, then we'll go to Representative Wilson.
Thank you, Mr. Chairman. I just had a question on the providers, the 18 providers. I've often wondered if there's any consistency in terms of their reimbursement services. I mean, do you have any data on that in terms of those base? I understand the base payments and the per hour, and maybe those are similar, but do you have any data which shows some differences or similarities between those 18 providers in our state?
Mr. Chairman, Senator Schuler, absolutely, and happy. Again, we could spend about a week of a presentation here carving it up by center, you know, who is able to provide what that service provision and volume looks like. But happy we can have a discussion offline and determine what would be best to see, you know, by center. But I think your question is well intended, and it's absolutely right on that you have different centers around the state that provide different levels of service, especially on the residential side. Like I mentioned before, it's just not something that, wouldn't it be nice if we had a crisis stabilization facility in every community? That would be great for Title 25, but the cost structure likely for brick and mortar and demand would not make sense there. But happy, Senator Schuler, to provide that breakout. On the next, I believe 2 slides from now, we'll show the aggregate funding just by fiscal year, but just keep in the back of your mind, all of that could be carved out by center. We certainly have all of that data, but didn't choose to put the volumes and volumes of that both graphically or in tables in this presentation, but happy to provide that.
Anything else, Senator Schuler? Okay, thanks. Representative Wilson.
Thank you, Mr. Chairman. First, just a comment and then a question. One is regarding to Senator Kinski's discussion. And I look forward to looking ahead maybe to the slides on the payment mix, because I did look over it, but it's been a couple of days. You know, to remember that most people that these centers see, if they're adults between the ages of 19 and 64, are probably not covered by Medicaid because we have not expanded Medicaid. So, you know, the discussion of Medicaid's mix is maybe not as relevant to the patients that these people see as we might like to think of, because they probably haven't got any coverage. But then I have a question for Stefan, which is, if you could remind me, are these 1-year contracts or 3-year contracts, and are they capped? So for example, if in coming up with the contract amount, they hypothesize, let's just say 100 patients of the general population at $87 an hour and 200 patients with priority populations at 120. If your population mix changes, for example, after we did our some of our criminal justice reform and the House Bill 31 last year, you know, trying to get more of the post-discharge corrections patients in there, and many of those might be in a priority population. So I guess what I want to understand is, are they capped at a dollar amount that was set when they wrote the contract, and they're really in trouble if their patient mix acuity changes, or how does that work?
Mr. Chairman, Representative Wilson, it's a great question. And I think the simple answer is yes, that we don't pay in excess of that contract amount. And to your question about 1 or 3 years, I believe right now we're on 2-year contracts that they do term on June 30th this month, and will be renewed. I don't know, I have to double check with our behavioral health division folks if they are doing another 2-year period, if it will be 1 year. If memory serves from discussions over the past couple of months, it will be a 1-year contract, but can follow up on that. But we moved a couple of years ago to 2-year contracts to reduce some of the administrative costs and burden on the state, especially in kind of a downed revenue environment of not having to do all the contracting. But you're right. So this is a question of funding model, and all models are bad and some are better than others. So there's pros and cons to whether you're straight fee for service, whether you're a grant model, whether you're somewhere in between. You get what you pay for, so to speak. And we don't have the ability when a center delivers in excess of its service hours, that is essentially, for lack of a better term, not reimbursed. On the other end of the coin, there are centers that on a monthly basis or on an annual basis might not hit their service target hours. And historically, the money has still been paid in full. So it's kind of a mixed bag. And again, it makes me, and again, maybe some of the providers or behavioral health division folks might scoff when I say this, but I go back to the history that, again, it's largely rooted in this grant model that was intended by the state years and years ago to kind of pay for this fixed cost and infrastructure to be available, both on an outpatient and then later on a residential basis in some communities. And over the years, because of the landscape of coverage changing, because of cost issues, revenue issues in the state, it's kind of been, and I'll say this as a bureaucrated to death in many respects, where you start adding elements to the contract, adding requirements to the contract. Well, now you should do this, or you can't do this, or you can't do this, when again, the history is kind of rooted in a grant program to make sure we have infrastructure across the state. So Representative Wilson, a mixed bag on if a center goes above and beyond its sort of state requirements or doesn't hit that target. Not a whole lot of adjustments happen there, but through the state contracts, we are able, when targets aren't met, to withhold funds and do corrective action plans, try to get service delivery up in instances where targets aren't being met. But again, it's just so different from an insurance or a fee-for-service model where you're essentially paying when the service is delivered and being billed through a claim system. It just does not operate that way in this system.
Mr. Chairman.
Please.
So Representative Wilson, thank you. The first part of that statement, I think, kind of closed the loop in terms of this slide, which is that it's a fixed contract basis. And as you noted, most of the people coming in don't have Medicaid. There was a time before we threw Medicaid billing wide open where that person with Medicaid might have been more likely to come into a mental health center, more likely screened by somebody who's with a higher level of licensure as to the adequacy or compliance with criteria for any services they receive, and then they could bill and collect that Medicaid. Now that patient that's got Medicaid or private insurance can walk into any social worker or mental health worker. And so that potential fee-for-service revenue that would help support the community mental health centers is gone. And I'm not, I don't think we can revisit that decision. Once you let all those providers start billing, they're going to start billing. But the point being that there are fee-for-service by-the-hour providers out there, not on a contract or grant model, who can just bill and bill and bill and bill. And that's a revenue stream that is reduced or impacted for the community mental health centers, which are on a fixed basis. So, but you're correct, Representative. My understanding is most people walking in don't have any coverage, and this is the provider of last resort.
And Mr. Chairman, may I address that as well?
Please, as you do, maybe you can clarify for me, because I'm a little confused with what I heard from Chairman Kinski on this, is that if the person is on Medicaid, is eligible to be billed by Medicaid and is seen by a private provider, they can bill Medicaid repeatedly. But correct me, but I think that the community mental health centers would have that same opportunity. And so if you could maybe incorporate that into your comments, please.
Mr. Chairman, that's right. And Senator Kinski, it's no different than, another medical service where a individual on Medicaid or on private insurance is essentially free to choose a provider that's in network or on the Medicaid side, an enrolled provider. So you're right that some changes were made years ago to kind of open that up a little bit, and there's benefits and bugs to any decision like that. In this case, increased access for Medicaid beneficiaries is certainly a good thing to be able to choose a provider. But you're right, over the years, especially with the advent of the Affordable Care Act on the private insurance side, more mental health and substance abuse reimbursement on private insurance, it does open up the market for providers. And but to Representative Larson's, Chairman Larson's point, it is certainly something that the community mental health centers that enroll and can bill Medicaid could, for lack of a better term, compete for the same clients. What I want to do, at the risk of getting on a quick soapbox, is I think that forces the conversation that this committee and others have wrestled with over the recent years, which is kind of that role of the state question when it comes to what is the purpose for the community mental health and substance abuse system in this landscape and era of a change in the coverage for these types of services, both on the private side and on the Medicaid side. And it's not, it's not an easy question to answer, but I think it's the fundamental problem to solve is how does the state now want to set up this system and for whom? Because Senator Kinski, to your point, you're absolutely right, where a community mental health center with the services that it provides, in theory and oftentimes in practice, can provide much more in terms of community-based and wraparound services than, say, a private psychologist who really only wants to or only does provide counseling or something to that effect, where a community mental health center in its history and in its origin was supposed to be kind of a deinstitutional type of framework to get people out and keep people out of institutions or higher levels of care or settings like that. So it really comes back, Senator Kinski, to your very good question of what is the role now of that system given this new landscape of mental health coverage and service provision in the private sector that is just here with us.
Comments? Scanning. Okay, Stefan, please.
Thank you, Mr. Chairman. Slide 17, members of the committee, for the state contracts for community mental health and substance abuse services, just wanted to give the committee, like I mentioned before, a general overview of the priority populations that are included in the contract language. On the mental health treatment side, children with severe emotional disturbance, or what's often called SED, Adults with serious mental illness or SMI and veterans are part of the priority population categories that, like I mentioned, in terms of the grant and how it's invoiced, are reimbursed at $120 per hour on the outpatient side versus the general $87. On the substance use side, Mr. Chairman, about 5 categories, some of them overlapping somewhat, but pregnant IV drug users, pregnant women, IV drug users, women and parenting women, and veterans. So again, some overlap across those categories. But again, just want to point out that you can see in the text below, those populations are reimbursed at $120. And again, reimbursed kind of in quotations at $120 per hour. And all other populations are at that 87 figure. Mr. Chairman, I see Representative Wilson has a question.
Yep, she does.
Thank you, Mr. Chairman. So Stefan, since we passed House Bill 31, I think I'm remembering the number right. All right, let me back up. Could you identify for us the prioritization? Is that primarily driven by state statute, by SAMHSA regulations? And then as we get into, I assume, the new contracts, you're going to work in the Department of Corrections post-discharge population. Could you just let us know where the priorities come from and what you see with the corrections folks?
Mr. Chairman, Representative Wilson, I'll take that in kind of blocks. First question, yes, the priority population categories that you see here have been kind of adapted and brought over from the federal priority populations, which is, as you mentioned, from SAMHSA. That stands for the Substance Abuse Mental Health Services Administration, which is a kind of a subsidiary of the U.S. Department of Health and Human Services. They have a mental health and substance abuse block grant, federal dollars that come to states, and we receive it also. It's relative to our overall program budget of, on a biennium basis, around $100 million for this. It's relatively small, I think 3 to 5 million, if I'm not mistaken, but can follow up on that. And those priority population categories, I'll just read them to you. On the mental health side, adults with serious mental illness and children with serious emotional disturbances. So you can see, with the exception of veterans on the state priority populations, largely mirrors the federal requirements, and likely going back to again before the state really increased its investment in this program area. The mental health and substance abuse block grant from SAMHSA for many states was a larger share of the funding for these types of services. So I think it's kind of a natural progression, natural history to have defined the populations in a similar way. On the substance abuse block grant from the federal government, just read you these priority population categories that my fine folks at the Behavioral Health Division sent over. Pregnant women and women with dependent children, IV drug users, tuberculosis services, early intervention services for HIV and AIDS, and primary prevention services. So a little bit different on the substance use side, but again, relatively broad categories with the exception of TB and AIDS on the federal side. But what I want to point out here, Mr. Chairman, the last 2 bullet points, in terms of these populations, our data shows that approximately 65 to 75% of all of the clients served fit into one of these priority population categories as defined by the contract. So as defined as the categories in the table that you see above there. And for substance use disorder services, about 40 to 50% of all of those clients fit into a priority category as defined by contract. And that does fluctuate depending on the fiscal year. And Representative Wilson, to your comment, the client panel will most certainly change year to year, month to month, even week to week at a center. But in terms of what we see in priority populations and how they're defined, that's what our data shows from our community mental health and substance abuse centers. What I want to just briefly address and kind of throw this out there for the committee is there, I think if you asked 100 people, legislators, executive branch, members of the public, who are the priority populations for behavioral health in Wyoming, you probably get 100 different answers. So again, going back to my comments about the tough task that a committee like this or others studying this issue have is determining, what should those priorities be? How should those populations be financed? When you say, well, let's look at the state hospital population, the corrections population, or populations like this, general categories of SMI or SED. I think it's a tough problem to solve, and there's many different ways to solve it. But again, it comes down to kind of what is the role of the state in this system. And I think the question that many committees have been grappling with is in this era of behavioral health funding, and both on the federal side, the private insurance side, some of the data and materials I presented before, the tough question is, what should the role of the state be in a system like this, especially, and I hate to say this, but especially in the situation that we're going to face and that we're working on right now, is really a significant trimming of state budgets because of the revenue situation. Really puts us in a unique and tough spot to answer these questions, especially as we anticipate very significant budget reductions going forward as quick as the next month or two across the Department of Health and other agencies.
So Stefan, could you give us a couple of examples of non-priority type situations that would come into the community mental health centers?
Mr. Chairman, sure. It's and I think the service array that would be available in a particular center that someone would go to or call for services would be the same. So it's just their needs might be different. And for example, and I'll just use myself as a hypothetical, I could call locally here in Cheyenne, my community mental health center would be Peak Wellness. I could call Peak Wellness Center and say I'm struggling at work or at home, or I have some issues with substance use. Definitely not true, but could call Peak Wellness Center, and they would ask for if I had any insurance, and I would be insured by the state plan. But in the hypothetical that I wasn't, Director Ceballos decided to fire me, I lost my state insurance. I could also go to Peak Wellness Center with that same kind of call of, I'm not, dangerous or violent or suicidal, but I'm having some problems. I could benefit from talking to somebody. That would not fit me into one of these priority population groups, but could still theoretically, if I didn't have my state insurance, would be covered, so to speak, at Peak Wellness Center by the state contract. Does that make sense, Representative?
Yes, thank you. Representative Wilson.
Thank you, Mr. Chairman. Just to follow up, but so Stefan, so I didn't really hear. So is the thought, since we passed HB 31, to, as you draft the new contracts, I assume this list of priorities is part of the contract so that they know which ones they're getting paid what for. Is the corrections population going to be added to the list?
Mr. Chairman, Representative Wilson, we are working on designing that corrections program. Now, whether that happens when the new contracts start on July 1st or whether it's incorporated, once we've worked through those issues of what that looks like, I'm not sure exactly on the date, but yes, that would be similar in whether it's part of the quote unquote priority population categories that are defined in the contract, or kind of a separate line item on the statement of work or the deliverables, should have the same effect. But I will mention, as you know, Representative Wilson, that and I think our provider association made a lot of comments about this during the interim. That was not an additional funding source or an appropriation to incorporate that. It would be essentially, like we've talked about, a microcosm of saying, okay, here's a priority population that we think if provided services in a different way or a prioritized way could reduce recidivism in the correction system, and maybe create some efficiencies or save some money for the Department of Corrections not to have to contract for more beds out of state, et cetera. So it's a really nice microcosm of the larger issue that we're talking about here in that, who are the priority populations and how should they be financed? And I think that's something we will experiment with this year, largely dependent on what happens with our our budget reductions, but we will experiment with that of how to incorporate, more specifically a priority population, and as the bill states, develop, which we will develop over the course of this next fiscal year. I think it was called a competitive outcomes-based funding stream for that population. And that's something that, again, is a welcomed experiment and exercise to kind of change the landscape of how some of these contract mechanisms work to pay for outcomes as opposed to paying for volume. So Representative Wilson, we're working on designing that. I just don't know the date of implementation at this point. Mr. Chairman, moving on to slide 18, like I mentioned to Senator Schuler, here's a breakdown on the community mental health and substance abuse treatment funding by source and by fiscal year. So updated through the current fiscal year 2020. You can see it broken out by general funds, federal funds, and tobacco funds for the total there. And then the last two columns, we do have primary and what are called secondary contract elements. And just real general explanation here, there are certain elements of funding to community mental health and substance abuse centers that are I think, more specific. So things like peer specialists, legislative acts that might be passed. Representative Wilson, I know there was no appropriation on the House Bill 31, but other programs in previous years have been, hey, do this at fund this service. And so those are what we largely consider secondary contracts or contract elements. So you can see it represents a relatively small or smaller share of the total. But we are, for fiscal year 2020, looking at about $55.7 million total contracted to community mental health and substance abuse centers. And that includes all of those funding sources. On the general fund side, about $43.3 million in this most recent fiscal year contracted to community mental health substance abuse centers. So like I mentioned before, the total biennial appropriation across these units, mental health outpatient, mental health residential, substance use outpatient, substance use residential, has been historically around $100 million a biennium. After the cuts from 4 or 5 years ago, we're sitting at around $98 million. And then through those secondary programs, there's peer specialists, other things that have been added in the past. It still sits, and I know I'm talking about millions of dollars as if it's something to write off as budget dust, but it is helpful to think about it, at least for me, in the department's budget as about $100 million overall program on a biennial basis. Mr. Chairman, I will stop there on sort of the community mental health and substance abuse contracts, populations, and funding before I move on to sort of an overview of the gatekeeping statutes per your request. But only a couple slides left, and then happy to answer any questions. But I'll stop here since I gave you kind of a 30,000-mile-an-hour overview of the community system.
Questions, committee?
Mr. Chairman.
Please, Senator.
Mr. Chairman. Stefan, I have a December 12, 2019 memo from Mike Ceballos that answers a series of questions that were posed to the department. And I appreciate that memo. There's a question I posed that is germane to this slide 18 that maybe I got an answer back on and I missed, which is I forwarded a study, I think it was a Pew MacArthur study, that showed that the percentage of mental health and substance abuse funding state by state that comes from the general fund as opposed to Medicaid and other sources. 40 states have a lower percentage of their general fund going to MHSA than Wyoming. And my question was, is there any way that we could increase the percentage that we're shifting over to the Medicaid program? And conversely, why are we spending, this was in 2012, the most recent number I've been able to find, 68.6 of MHSA spending in Wyoming comes from our general fund. And there's other states that, Washington State, 23%, For instance, Pennsylvania, 20% comes from general fund. And strictly speaking, that's a broader question than this slide, but I was hoping that when we look here and we see 43 million in 2020 from state general fund and 6.9 federal funds, and then TSF, what I'm not sure what the TSF stands for.
Tobacco
But-
settlement.
Okay, tobacco. So, but 43 over 55, that's coming out of the state general fund. What could we do to impact that balance if we just left the model otherwise alone, their mission and what they're doing? Is there any way to shift that so that it's closer to a 50-50 split?
Stefan.
Mr. Chairman, Senator Kinski, great question, and happy to revisit it right now after our discussion at JAC several months ago. You're absolutely right. In that study and others that have been done in more recent years, Wyoming is in a minority of states, I would say, that don't have a larger share of federal funds or Medicaid spending in their mental health and substance abuse community programs. And there's a variety of reasons for that. But to your specific question of, no mission change, let's assume no mission change, no role of the state conversation, no big reform projects, how could we get a larger share of Medicaid paying for these services? And a simple answer to that question is operationally challenging. And so what it comes down to for Medicaid is eligibility. And like Representative Wilson mentioned, Medicaid eligibility in Wyoming compared to states, for example, that have expanded Medicaid under the ACA is more limited and population or category specific. But, we've talked about this in concept in the past that for example, let's use me again as a hypothetical. I don't have I get fired from my job. I don't have insurance, and I go to Peak Wellness Center and they say, do you have Medicaid? And I say, no. And maybe I even do a Medicaid application in that week that I'm enrolling for services, and I get turned down. So I don't have Medicaid, I don't have insurance, and now the state contract for Peak Wellness Center is essentially picking up my services. That could very well change in the next month if I met a Medicaid categorical eligibility criteria or something in my life changed that would make me eligible. What it would require, again, operationally more challenging, I would say, is for regular periodic screening by the provider for Medicaid eligibility, if that makes sense. So that's something that could certainly be done. It comes at an operational and potentially a monetary cost to continuously screen for either insurance or eligibility for Medicaid to see if that reimbursement could be there. So that's one, Senator Kinski, to your point, that's one thing that could happen. I'm not saying it's a good idea or a bad idea, but that Medicaid churn, as you know, we see about 20 to 30% churn in the Medicaid program where someone's eligible one month and not eligible the next month, or vice versa. So that's one way that Medicaid reimbursement into a system like this could be improved, for lack of a better term. The others, and I don't mean to suggest this, mention this without judgment or comment, that some of the states that you mentioned, I know the study was prior to the implementation of the Affordable Care Act, but those states that you mentioned, Senator, have expanded Medicaid under the Affordable Care Act. So that's another way that the population served in community systems like community mental health or substance abuse, when states expand Medicaid and now get a 90% reimbursement from the feds, many of them have eliminated state funding or reduced state funding, I should say, for community programs because they're leveraging those federal dollars. Comes with benefits and bugs, as everybody knows. It's just different systems being introduced there. The last thing I'll mention, third, Senator Kinski, is something that's been tossed around as an idea for a number of years, both in the department, governor's office, the Joint Labor Health Committee, is the idea of another waiver for Wyoming Medicaid. We have a handful, I think 3 waivers in Wyoming. The ones that you might know about most is our waiver for the developmentally disabled. That's a Medicaid waiver program, and what we used to call our long-term care waiver, now known as the Community Choices Waiver. Essentially, a waiver is something that instead of providing a service or in lieu of a service like skilled nursing facilities, you can carve out a home and community-based service for a specific defined population to essentially waive out of some federal regs in the Medicaid program and provide an alternative type of service. There are states that have done what we call adult mental health waivers, where a specific population is defined, maybe meeting a clinical criteria, an income criteria, both, and provided essentially waiver services or a waiver budget with a defined network of providers, et cetera. That's something that, again, Senator Kinski, to your question, could be pursued. I think the natural question leading from that is, how do you finance the state match for another waiver program? And that waivers are typically reimbursed at 50-50. So 50% state match and 50% federal funds would be required to do that. And the funding source, whether it's this budget in community mental health and substance abuse, that's another way, and again, just speaking on the financial side, to leverage more federal funds. So I know that was a long-winded answer, Senator. Hopefully it made some sense, but want to make sure that I answered your question. Happy to follow up if not.
Follow up, Senator Kinski.
Thank you. No, none. Thank you, Mr. Chairman.
Other questions? So, Stefan, I know we've got a couple other slides. Give me a little indication on your time frame on these two slides. Are we going to be another 15, 20 minutes? If so, I think we'll take a break. If you think it's less than that, then we'll plow through.
That's a good question, Mr. Chairman. So it looks like I have 2 slides left. Representative Barlow and I did work a lot years ago on the gatekeeping program. So really depends on the level of discussion that we have there. I could go through these slides in another 3 or 4 minutes and then maybe come back for questions after the break. Totally up to you, or we can break now and wrap up afterwards.
Committee, I think we'll take a break. I think we'll come back at it's 10:17. I think if you would log out, or stop your video in silence, and then we'll be back at 10:30. There was no objections there, was there? Whew. Hi, Eric.
Hey, Lloyd, sorry. I got
Are we back, John?
Yes, Mr. Chairman.
So committee, I want to, a couple of things before we move on with Stefan, is that here in my office, we got some funky internet stuff going on. So if I disappear, Senator Kinski will jump in and move forward. I think, Stefan, for you, if I might ask on the funding portion of this, if you look at our agenda, this would be an appropriate time to do public comment on the funding portion before we move to gatekeeping. But I'd like to know for you on the funding aspect of it, is there anything else on any of the handouts that you give us that you'd like to cover before we go to that public comment? I'll unmute you. There you go.
Mr. Chairman, I apologize. Was that a question for me or for the committee?
Want me to ask again?
Please.
My children pay that much attention when I speak too. So, so my question is we really probably should be going to public comment if you're done with the conversation on funding and before we go into the gatekeeping portion. So is there any other portion of the handouts that you give us regarding funding or anything else that you would like to cover on funding before we go into public comment?
Mr. Chairman, thank you for repeating that. And no, the only two things I might mention just in closing on the first part of that presentation is, number one, in addition to the slide deck, would like to point the committee members to the memo that Senator Kinski referenced that we prepared and sent to the Joint Appropriations Committee in December in advance of our budget hearings that attempt to answer a number of questions about the funding stream for community mental health, as well as Medicaid provision and service delivery for behavioral health services. So to some of the discussion items from this morning about opening up the market, so to speak, for additional providers to be able to bill Medicaid for behavioral health, we did try to address a lot of that in that document and in that memo. Which I believe the LSO distributed to all of the committee members. So we're happy to follow up on those items or answer any questions that the committee might have now or in the future. Feel free to funnel those through LSO or contact us directly. And then the last thing, Mr. Chairman, that I'd mention just as we close out kind of the background on community mental health and substance abuse funding and contracts is, again, not to sound like a broken record, but I think the fundamental question for us, even in the executive branch, is very similar to what the facilities task force grappled with 6 years ago, actually, where now that project, that task force's work is starting to reach culmination when it comes to the facilities in Evanston and Lander being reconstructed, new missions, new populations. It's obviously not identical, but it's very similar in concept to the problem that we've all tried to address, solve, analyze over the years when it comes to mental health and substance abuse services, and that is, again, the role of the state. So going back to the facilities task force, those hard questions were discussed, debated, and ultimately answered in statute on what populations should be served at the state hospital, what populations should not be served at the state hospital, and concurrently what populations should be served in the Wyoming Life Resource Center and what populations should not be served. Again, not an easy conversation to have, but one where I think there's a model going back to that task force to potentially replicate something similar between the legislative and executive branches when it comes to a system like this, on missioning that type of system for the future, for a sustainable future, given the landscape that we see with behavioral health, with financial issues, with coverage, with Medicaid, with private insurance, Affordable Care Act, all of these different things that have changed over the years. Again, that just seems to be what we keep coming back to in the department is not, and Representative Barlow, not to throw you under the bus, but you've brought this up a number of times over the past year or so. What does the statute say? And a lot of the statutes are antiquated. And, coming from the 80s and the 90s on local or county-based mental health boards that made funding decisions, and it has just changed over the years. And so there's a response or an instinct to go, let's go change those statutes, let's go update them. And that's exactly what the facilities task force had to do. But they started with, let's talk about that role of the state. Let's talk about the populations that are currently served and where, kind of similar to what we outlined, not in much detail, but this morning on the general, state of behavioral health across different funding sources. And we can go deeper in quantifying who those populations are, quantifying as much as we can, where are they being served, how are they being served, are they being served, to try to help answer those questions that would come from that is, okay, now we know the landscape. Now what's the role of the state in are we a safety net? Are we a general access? Before we talk about vehicles, policy, and legal to make changes like waivers or funding source changes or rate changes or rebasings, whatever you want to call them. I think those fundamental questions, again, apologize for the soapbox, Mr. Chairman. We have a model from the Facilities Task Force that I think really did some good work in answering those tough questions from the policymaking standpoint of what truly is the role in the provision of behavioral health services and to whom.
Thank you. Committee questions before we go to public comment. And I would just request also, committee, as we go through these, as you have these questions and ideas come to your mind, whether it be on funding priorities or who the state should serve, I'd hope that you'd write those down, and we'll collect those questions and develop how the next meeting looks and what we address. Okay. So with public comment, we're going to kind of take these in order of how they were submitted. I think each of us received a letter from Sean Humberson. Hope that was passed out. She is not going to be making public comment, but wanted her written comments presented to the committee. You should have that. I think in order of public comment, we'll first hear from Paul Demple, the CEO of Northern Wyoming Mental Health Center. He'll be followed by Andy Somerville, who represents WAMSAC, and then they will be followed. I think Paul is going to set in with Andy on that presentation, and then we'll be followed up by Cheryl Foland, and then we'll get to that point, then move on to gatekeeping. So Paul, if we can let Paul in and take his comment, and he's provided handouts as well. Good morning, Paul.
Okay. Can you guys hear me?
We can.
Okay, thank you. Mr. Chairman, members of the committee, thank you for allowing me to speak. I'll keep my comments pretty brief. What I wanted to do was, and I really appreciate the Deputy Director's presentation. I think I broadly agree with it from a 30,000 foot view. I just wanted to be able to come on and say, okay, how does that trickle down to a mental health center? And to give people some feedback, I've been in the system, working in the community mental health system in Wyoming for about 31 years. I had 26 years at Central Wyoming Counseling Center, and then came up here to be the CEO about 2015 up in Sheridan. Northern Wyoming Mental Health Center covers Sheridan County, Johnson County, Weston County, and Crook County. So you can see although we're a medium-sized center, we cover some very, very rural areas. And my intent here is just to, and again, the data I'm going to present to you is straight out of my system. I sat down, pulled it out, and plopped it on here. So with that, I'll walk through if people, I'll try to pay attention. I'm going to share my screen to make sure people know where I'm at. And then, Mr. Chairman, is the protocol, this is new for me as a protocol, then you'll kind of signal me that somebody has a question, or.
If someone has a question, I'll stop you and call on them, Paul.
All righty, thank you. Okay, what I'm going to do is I'm going to share my screen if I can do that, which is, I think, sorry. There.
Yep, you're doing something. There, you got it.
Does it say who do we serve?
It does.
Okay, thank you. So I wanted to, I mean, it's more complicated than this, but a lot of the questions that over the
We're
years.
seeing it's pretty large. We're seeing only half the sheet.
Oh,
So you might have to scroll down as you move along.
well, how's that?
That's a little better.
I can even go smaller. I'm
Well,
an old
no,
man. I have to blow everything up.
There you go. There you go. Thank you. Got both pages.
Okay, maybe I'll go up just one more.
I wouldn't.
How about there?
Now we're back to half a page. You're piddling.
That's
Okay.
that's perfect though. He can scroll down. I can't read it when it gets too small.
Oh, I am going to scroll down. Okay,
Yeah.
so
Scroll
I'm
down.
going to start here. Can everybody see this? Okay, who do we serve?
Yep.
So I went through and I said, you know, we have these identified populations, priority populations, and I took this from our system. And right now, the folks that have the checkbox as seriously mentally ill, about 75% of the folks who we see, and these numbers are pretty stagnant. I mean, year to year, could be identified as seriously mentally ill. There's some other numbers that aren't in here because we'll do evaluations for people we've served, but we'll evaluate and then we actually don't provide them services, but they'll get counted in the overall numbers. But by and large, 75% would clearly qualify as seriously mentally ill. On the substance abuse side of all the people we see, 97% are involved in the criminal justice system. Now, out of that, when I say criminal justice system, there's a large chunk of those folks that are on probation. There's a smaller number that are on parole coming out of prison. And then there's a subset that's criminally just involved. So we have all kinds of people that aren't in prison yet, but they're somewhere in the system. So we're providing services, they're in court, they're in that system, but wouldn't fall under the previous two categories. And so within substance abuse, 97% of the people we're providing services to are doing something in the criminal justice system. How do we get paid? Again, I just ran the numbers and said, what are the primary benefit assignment? And I'm not going to get down into the weeds, but in my world, there's primary, secondary, and tertiary benefit assignments. Primary usually is who's paying first, and then everybody knows about with multiple insurance, it can waterfall. This is how my breakout is currently, and I just ran this last night, that about 19% of our folks are primarily Medicaid, 13% Medicare's identified, 25% have some sort of private insurance. And to give some view on that, and this doesn't include Medicare or Medicaid, just private insurance, we're dealing with, at any given moment, the count right now is 172 different insurance companies. There's tons of them. And then there's the folks that what we're calling is self-pay. So they don't have Medicaid, they don't have private insurance, they don't have anything else. And then there's that 3% other, and we have kind of some odd offshoot things, like say we got contracted for an EAP, or a school district specifically contracted with us to do something for a specific kid. That's not much. So that's how our benefit assignments currently for Northern line out. Then if I go to number 2, what's the actual income? And what I did was I ran this through this fiscal year through May 28th. So it doesn't include June. 52% of the number one money coming in the door from providing services is from the state contract. Fee income, now that includes Medicaid, private insurance, anything where we do a fee for service and somebody pays us goes into that bucket. And that's about 13% of our dollars. Then, and the reason I broke up the next 3 this way is because that's how our contracts do it. So the next, there's federal substance abuse grants. And so that supports the substance abuse services. And so that's 13%. And those are federal dollars. The tobacco funds is about 13%. And then, and this is going away this year, but there was a Section 3 part of the contract that wasn't part of the general contract, where last year we could apply for it, or 2 years ago, I guess. we could apply for it to specifically provide gatekeeping, which we did. And so that was there. And then at the end of the day, how much money do we bring in from clients on the sliding fee scale? And I'll remind the committee that the community mental health centers, we're not a competitive, we're a private nonprofit, but we don't operate in the competitive realm. We can't, because the way our contracts are set up is that, yeah, we have all these things, and I am required by the contract to make sure people have insurance and all those things. And in fact, we check everybody's name every day when they come in for a service against a database in real time to say, are they on Medicaid? So we can capture that, and insurance and those kinds of things. The difference is, if I was just on a fee for service thing, I have to provide services to everybody regardless on a sliding fee scale. Anyway, so now, and I hope you can see number 3, the fee income. Mr. Chairman, if you just nod, you can see that.
We can.
Okay, so this tells you, because people say, well, who's insured and where's the money come from? So number 3 says, here's the breakdown. And the amount expected is what our usual and customary fee would be for some folks, which for insurance companies is $125 an hour for individual services. Our usual and customary fee for Medicaid is, used to be 87, but we got a cut. It's like, I think 84.12 or something. So on the Medicaid line, that's what we're expecting. So I'm not going to spend a lot of time on here. I'll describe the columns: amount expected, total amount denied. And then the third column is the total write-off. Well, what is that? So if we send a bill to an insurance company and they send us $100, but it was $25, but they have a secondary insurance, we'll go and try to get that, recoup those dollars elsewhere. If we just can't recoup them elsewhere, there is no secondary or anything else, then what happens is it's a write-off. So at the end of the day, if you take private insurance, we billed almost $700,000 and recouped about $170,000. I've seen these types of numbers my entire career. It's not unusual. There's talk about parity and everything, but and there's a lot of reasons for that. One of the reasons is people say somebody has insurance and they'll tick it off like we get paid. There's a huge number of folks who get insurance, but they're the working poor and they can't afford the deductibles and copays. And so they essentially have catastrophic, and we don't see any of those dollars because they don't have them. Anyway, I'll kind of leave that. As you can see, and then I'm going to the next, which says my comments. Private insurance is my lowest average service provider. And again, the average service payment, is $37.46 on average, knowing somebody's going to pay more, somebody's going to pay less. On average, for an hour of service, I get $37. Then private insurance is the largest unreimbursed. The other thing, when you think about the state contract, and this is where it really gets in the weeds, but this is the reality of my world. When they changed the state contracts to go to priority populations and then started saying anybody who has insurance the state's not paying for, in my world, what that meant was, the illusion was, if they have insurance, insurance will pay for it. But what really happens is, say an insurance company comes back and says, because of deductibles, copays, or whatever the reason, we bill, I don't know, 2 hours worth of $250 worth of services, and I get $10. That's what I get. And so from the state's perspective, insurance paid for that. From my perspective, I got $10 for $250 worth of service and nowhere else to count it. And I think what happened a couple of years ago, we went to priority populations and did this. Some of the committee's discussions, and certainly deputy director's discussions, was the system was really set up to say, we want a community mental health center system, and we're going to subsidize everything because we know people don't pay. And then we started getting into these things. And so we still have a community mental health center system by design, but the payment model has shifted to something else. On the sliding fee scale, which we're required to do on everybody that comes in the door if they don't have another pay source, my average service payment is $14. Now, part of and this is really in the weeds, but there's some of my folks who get their student loans paid for through HRSA. And in order to be able to do that and be signed up for all that, we have to have a sliding fee scale for everybody. It's just part of the deal. And that's where we get our sliding fee scale. And the state contract, you know, we don't set that. It's really based on their model. So anyway,
Paul, if I could, just avoid
yes.
the weeds. Avoid the weeds, please.
Okay. So last two things. What's happened in the community mental health center system. When I came here in 2015, we had 34 clinicians. Through a series of cuts, us not being able to get reimbursement, all of the things, when they opened up Medicaid, what happened was all the paying folks, so with kids especially and stuff, private providers kind of took those guys, some of them, we still have some, but then as soon as they run out of Medicaid, they're back at our doorstep. So, and we have to take private providers don't have to take everybody and can say everybody has to have a pay source. We can't. The current budget I'm working on 2 years ago, fiscal years 29 down to 26, I'm down to 20 clinicians. I'm eliminating positions. I've cut, I think, so far, and I'm still working on a deficit, $739,729 out of my current budget. And out of that, 686,000 is staff. And that's the reality of my world at the deeper level, is that we've been trying to make it work for a lot of years, but I think the system has been problematic all the way along, but we've been and now, especially with the COVID stuff, what has been problematic, it just highlights it. And this isn't hyperbole. You know, I started out with an $800,000 deficit because of a lot of things, right? I've got it down to maybe 100,000. I'm still trying to figure out what to do with that last 100,000, knowing that I've got probably at least 10% coming from the state, possibly some Medicaid rate cuts. The other thing I'll tell you, when you see Medicare reimbursement, that's a fallacy. And that's a fallacy because just because somebody's on Medicare doesn't mean we get paid, because in the federal system, you have to have a licensed social worker. Mostly the people we hire, because of volume, is licensed professional. We lose all of those dollars because federally, and we've been trying to work with Senator Barrasso and NZ and everything to get exceptions for that for rural places, saying, because, you know, we're hiring people that we can get, and licensed professional counselors are just as well qualified, but we lose a ton of money if that counselor isn't an LCSW. So anyway, where are things going? I have no idea. I'm just trying to make things work. But my hope is this gives the committee, and again, this is just out of my system. I just said, what's it look like? And I threw it on here. So with that, Mr. Chairman, I'll stand for any questions.
Thank you, Mr. Dimple. Committee, any questions for Paul? Paul, I do have one. If you made the comment, and I'd just like you to walk me through how that works when you says that they'll go to another provider if they're on Medicaid, and then when Medicaid runs out, then they come to you guys, and then it goes that way. So is there a limit on the number of times you can see somebody if they're on Medicaid? Walk me through how that works and how that scenario would.
Mr. Chairman, I think it's probably 3 years ago, Medicaid instituted some changes on caps. And so what happened was, and the caps don't count per provider, it's total for the recipient. And so if somebody goes somewhere and burns out their Medicaid caps and the private provider says, we absorb those caps. And what happens is within the system, but it's not just the caps, because as the deputy director said, people kind of go on and off Medicaid. But in essence, what happens is if people consent, especially with where I've seen it primarily is in children's services, because those services tend to be very extensive. That can happen a lot. So it's more complicated than that, but by and large, is Medicaid capped? Yes, and we can apply to whoever their folks are. There's a different one now to say we need to continue to provide this service. Then what'll happen is they'll come back and approve like a month's more worth of services or something. So now we have to keep doing that. And what happens is sometimes there's a disagreement, although I will say it's gotten better, but we have had some instances where a person was in the state, decompensated, was in the state hospital for almost a year, got out of the state hospital, got onto Medicaid. We stabilized them, got the medications, everything. 2 months later, they said, we're not going to approve anymore except for once a month because the person is stable. And then this just popped in my head, and I'll throw this out there. I can honestly say when people think about what are we incentivized to do, I'd be shocked if you ask one of my clinicians who decide what the services are, if they could tell you what the pay source was. I would be shocked, because the people that decide the services are not me, it's the clinicians. And so what happens is they figure out that, this person needs X, Y, and Z, irrespective of payment source. If you see that on the subsidy side, group is by and large the largest services, that's because evidence-based practices say at an IOP level, which is a high level, like people that need a lot of services, the state requires that we follow our ASAM criteria and requires at that level that they get group. And it's the right thing to do because it's evidence-based. So those are really how our decisions are made, not based on what the pay source is. And the clinicians who decide, I'm going to do group or not group, aren't making those determinations based on pay source at all.
Okay. Thank you. I just wanted to get my head around that.
Did that help?
It did. Thank you.
Mm-hmm.
Very helpful. Okay, Paul, thank you. I think Andy's up next. If you can get us off your screen, Paul.
Oh, I'm sorry.
You're fine.
I'm new to this whole thing.
Aren't we all?
There. I didn't do that, by the way. I think Elizabeth did.
Representative Barlow.
Mr. Chairman, so thank you for the presentation. I actually seen some of this material before. One of the things that it looks to me like when I look and your screen is not shared anymore. So there's two categories. One is the payer mix, and the second one is the amounts received from the different payers. It looks to me like it was 40% self-pay and 3% other. And then when you got to the next column, it was 53%, I think, state contract. Well, 43 to 52, or maybe it's 43% to 52. And then you talk about the underpayment of private insurance, et cetera, non-payment with private insurance, et cetera. It seems like the only two payers that are actually paying probably at least close to what what's being provided is Medicare and Medicaid. Is that an accurate assessment? Thank you. And basically then state state contract makes up for everybody else's either inability or unwillingness to pay. Would that be correct, but at least based on the numbers you're presenting, Mr. Dimple? Thank you, Mr. Chairman.
Mr. Dimple.
Mr. Chairman, Representative Barlow, that is pretty accurate, but the only way I would change in the answer to your question would be Medicare. Medicare, I mean, I last year I brought in a grand total of $16,000 in Medicare because of the LCSW rule. So that's a little bit different, but the best payer is Medicaid. The only, by and large, if you're talking about a fee for service, and the system really is set up that way. The state is subsidizing all of this other stuff.
Okay. Any other questions before we go to Andy? Okay, Ms. Somerville, thank you for being here today. I think we're going to keep Paul on with you as requested. And if I could ask you, Andy, as you go through, if there's some of this stuff that Paul has already covered, please resist the temptation of sharing it with us again. And, but you're on.
All right. Thank you, Mr. Chairman. Andy Somerville, representing WAMSAC, the Association of Mental Health and Substance Abuse Centers. And Mr. Chairman, I will resist that temptation because Paul covered a lot of ground. So hopefully we can speed up the meeting just a little bit here. I'm going to share my screen with your permission.
Please.
Oh. It doesn't want to let me. It says there's another participant that's sharing still.
Can we help her out there, Mrs. Martineau?
Chairman Larson, you should be able to try now.
Okay. There we go.
We're not, there we go. It looks like we're getting close. There we are, Andy.
All right, great. So I just wanted to do just a real brief overview for the committee. And I know Labor Health has heard this from us before, but just a little bit about what makes up a community mental health center. So I want to thank Deputy Director Johansson for his presentation. He really covered a lot of those points as well. So I just wanted to show you this map. This is where all of your community mental health centers are that are members of WAMSAC, which is all of them but one. As you can see, we've got a presence in every county in the state, which is impressive in a state with as much rural area as we are. And one thing I wanted to highlight.
Andy, can I ask a question there? And this map actually spawned a question for me to Stefan earlier, because in Fremont County I see VOA there, but I thought Fremont County was our community mental health center. Is WAMSAC or is VOA a community mental health center, or are they just a member of WAMSAC?
Mr. Chairman, VOA has a social detox facility, the Center of Hope, right, that's in Riverton, that provides substance use services. So they are a community mental health center. They just have a small piece of a program in Fremont County.
Thank you.
Of course. So in terms of what makes a community mental health center, just to highlight again what makes us different is we really provide a comprehensive, Mr. Chairman, did you lose my screen?
We did. It's looked like we got Miss Foland that just started sharing the screen. I don't know, Elizabeth, can you help us out there?
Chairman Larson, go ahead again, Andy. I'm going to remove Cheryl from the waiting room for now so we can see if that will prevent that.
Okay. How is that, Mr. Chairman?
I think it looks great. Thank you. Right. Sorry about that.
Nope, that's okay. Welcome to Zoom meetings, right? So I just wanted to highlight that what makes a community mental health center a community mental health center is that it's a comprehensive community-based services for mental health and substance abuse, and it's regardless of the ability to pay. It really, the history of this, in the 1960s, there was federal legislation to bring about community mental health centers. We, as a state, as I understand the history, decided to go with the nonprofit model, as Senator Kinski indicated, kind of a quasi-governmental model, in order to pull funding down into the state to provide those services. And that's pretty much why we have the model we have now. But again, this, regardless of ability to pay, is a pretty important part because we serve everybody. And these are the lists. So you have outpatient, residential for both substance abuse and mental health. This is just a brief list of the services that are provided. Now, as Mr. Johansson mentioned, the services are not the same at every center, but they are pretty comprehensive for what's needed in that particular community and what that center is able to provide. So as you can see, it's much more than just counseling, frankly. It ranges from psychiatric services. They provide 24/7 emergency on-call response, especially for Title 25 assessments, group therapy. They also do something that's not always mentioned, is they do a lot of community engagement, suicide prevention and education. They respond in any type of emergency where mental health support might be necessary, such as a natural disaster or a pandemic. And they also do early intervention, diversion services. So it's a pretty comprehensive list in terms
So
of.
Andy, how many of the community mental health services have psychiatric services and how many do not?
So all of the mental health community, all the community mental health centers that are providing services have some type of psychiatric services. Now, what type, it varies. A lot of the centers, especially the smaller ones, contract with a nurse psych practitioner or a psychiatrist who provides those services via telehealth because they cannot afford to keep a psychiatrist on staff. Some of the larger centers do have psychiatrists on staff, so it varies a little bit. But it's really important in terms of the medication management. That's one of the issues that we've been talking about, specific to potential budget cuts coming up and what that looks like. It's psychiatric services is one of the most expensive line items for community mental health centers. I mean, sometimes psychiatrists can be $250 an hour to provide those services. And so how we're going to keep that going in terms of budget cuts is a recent discussion.
Thank you.
So I wanted to give you just a snapshot of what your community mental health services did in fiscal year 19. So that's our most recent complete data set right now. So you've got outpatient mental health, just almost 17,000 people were served, 265,000 hours. That's not a misprint. That's actually what was served. And then you can see here, we've talked a little bit already in the meeting about SMI and SED, and you can see that makes up a pretty high percentage. Over 2/3 of the percentage fall into those two categories as priority populations. In residential mental health, we have fewer data fields on that right now. Data is always improving, but for crisis stabilization, 370 people. Group homes, 152, and supervised living is 136 were served under the state contract in fiscal year 19. Outpatient substance abuse is a little less. As you can see, mental health outpatient makes up a pretty big bulk of the services, but they still served over 6,000 people and 160 program hours. And I kind of outlined just to keep you up to date, these were the primary diagnosis or issues that they were seeking treatment for. You can see alcohol, methamphetamine. I know we talk a lot about opioid epidemic, but opioids is pretty far down on our list. And then residential substance use, apologies, a little bit over 1,000 people, but 69,000 days in total when you take the number of people versus the days they were there. And I wanted to highlight this in the previous conversation today. We talked a little bit, I believe Representative Barlow talked a little bit about utilization rate for beds. This would be one of the categories that's paid per bed. The utilization rate was 91% for fiscal year 19. The contract target for those centers is 85.
How do I undo that? Sorry, it's happening live now. I removed someone accidentally from the meeting.
I think
that's Elizabeth.
Okay.
So Andy, if I could ask a question on that, why we have the voices, the mysterious voices coming on, was are those beds shared across from one mental health center provider to the other? I mean, do they enter if
Well, she tried to
the
join
mental
with
health
that.
center didn't have enough beds and they needed a bed in?
Is there any way we can, I know I was looking, the reason I called is because I was looking and there's a setting that says you can allow removed participants to rejoin, but I don't know where to click the button.
I don't know, Elizabeth, is that your speaker that's on?
I apologize, sir.
Thank you.
Mr. Chairman, if I understood the question is, basically was, do the facilities share beds when, yes. So they all work very closely together, and I'll give you the most recent example. In March and early April, due to cases at one of the facilities in Wyoming, the community mental health centers were participating in biweekly bed management calls to do exactly that, to rearrange beds so that they could have appropriate number of isolation beds, still provide crisis services. It was a logistical, interesting logistical conversation in terms of transport, but they do work very closely together.
Thank you.
So just in terms of what they have done, we're pretty happy with that. The next thing I wanted to highlight was just a quick overview of what the contracts actually look like right now. And I promise, Mr. Chairman, we won't get in the weeds. Deputy Director Johansson's already spoke a lot about this, but these were the changes that were made in 2018. So this particular set of requirements is still fairly new. And we had every intention of continuing to work with Department of Health to assess how these new changes were working and make modifications to them as necessary. But you'll see again, there's a 30% base payment, 70% service hours. There's priority populations. There is a 1/24th max payment. And I want to clarify that's on a biennium contract because it is a 2-year contract right now. So just to highlight that conversation that was had before, this is a fixed contract. So when the centers outperform their contracts, they don't get any more money. Now there are potential financial penalties if they don't perform to their contract standards. They do have some room in the contract to request exception payments and things along those lines, but there's no more money. There's no avenue for that. Also wanted to highlight in this contract, that their contracts require that they keep operations in each county that they have a contract for. So physical operations, that is something that may be up for discussion depending on how budget cuts roll out. So Mr. Demple's center runs in 4 counties right now. He has a primary location in Sheridan and then 3 other counties that are served with smaller offices that are kind of a remote office, if you want to say. And they're already in discussions, potentially what that'll look like. And Mr. Demple's center is not the only one. If you remember from the map, we've got several of our community mental health centers that are serving 2, 3, 4 counties. Their contracts also require that they must serve everyone. I think that's been highlighted pretty well. They can't turn anybody away, even if they've maxed out their contract. And I wanted to highlight here, and I'm happy to bring some more specific data back to the committee if you'd like, but the majority of centers significantly outperform their contracts. I can speak to the last 2 years of data review, but they're consistent in that. On residential, for those
explain what that means, Andy, to outperform, that they provide services for more than their contract compensates them for. Is that what you're saying?
Yes, they certainly did. So example, if their contract had 1,000 hours a month of service, they provided 1,300 hours of service. They got their payment for 1,000 hours of service and didn't receive any additional compensation. But again, their contract specifies that they have to serve everybody, that they can't turn anybody away. And then on the residential side, just a quick example, these contracts are a little bit different. As Mr. Johansson highlighted, they can be in the same contract, but they have different requirements. Again, on the residential side, they get equal payments over the course of the biennium contract. They have to hit these utilization rate, completion rate for the program on the substance use disorder side. And then just highlighting that in the recent years, we have also added reporting requirements to track outcome base. So that's part of their contract as well. With your permission here, I'm going to jump down a slide that I had later, but it seems, again, just to highlight one item in terms of discussion that's already happened. On the contracts now, what has changed since about 2010? Those Medicaid caps, I wanted to clarify, when Medicaid was open to private providers a number of years ago, before it was opened, community mental health centers were the primary Medicaid provider essentially in the state for mental health and mental health services primarily. So Medicaid pays almost nothing for substance use services. But the only other eligible billers before the change was psychologists, psychiatrists, and MDs. And so the discussion about that revenue change that happened, there was a loss of revenue in terms of those Medicaid clients that went out to private providers. So I just wanted to highlight that for you guys. Very quickly, this is just a shot of what Paul Demple already presented in terms of his payers and average service payments. If you have any questions on that, I'm happy to answer them, but I think I'll skip over that. On priority population, so this is the new piece of the contract that was added in recent years. Director Johansson went over this very well. I just wanted to highlight, so this criminally involved related to House Bill 31. So in the current statement of works for the contracts that would start July 1, there is a definition in there for a target population, essentially is what it's called, for probation and parole. So that is all, assuming that that remains in the contract through the rest of the review process and those are signed, that will be in there as a first step. At least that's what my centers have seen in their contracts. And again, on this particular conversation about the DOC population, what we're finding in this is that we need to continue to tighten up the data. The data my centers have says that they are already serving this population under the state contract quite a bit. Some of them, some of the centers have 30% are probation parole. As you heard from Mr. Demple, some programs are well over 90% are criminally involved. So in line with House Bill 31, we're working with Department of Health to continue to tighten up those data reporting requirements so that we can accurately capture that and report that back to the state. Mr. Chairman, I have a little bit of discussion. There was an agenda on the item on the agenda, my apologies, regarding assessment tools used to determine severity scale of patients. Would you like me to speak to that since it wasn't in the Department of Health presentation, or would you like to skip that?
No, I think go ahead. Help us understand how you do that.
Okay. Well, Mr. Chairman, I don't know how much I will help. I am not a clinician, and I was told pretty much to stay out of the weeds by my providers as well. There are numerous tools, ASAM guidelines. There are tools such as the ASI and other items that they use to assess severity of patient. The difference, so right now we have priority populations, so there's no increased reimbursement if the client has high needs or is extraordinarily complex. With potentially changing that to a severity basis, that could potentially change, but that conversation is probably going to take a little while and is complicated. What we've seen in terms of priority population data is the reporting has continued to improve, but what my centers are reporting is that their client mix has not changed really. What we've done is, again, tightened up the data reporting requirements to get a better idea of exactly who we're serving. And so in terms of whether we want to go down this road or not, I think we have to ask a couple of questions. So if the contracts are over-serviced right now, does an incentive based on either priority population or severity truly work? Does it matter if they're maxing everything out? The cases that are presented today, when somebody comes in for their initial assessment, they never check one box. They never say one thing is wrong. The cases are complex. They're polydiagnostic. They're dual diagnosis. They're not simple anymore. And so how do we account for those services? Right now, we really don't. Again, it's a straight payment on the state contract, either priority population or general population. And then to ring the bell that Deputy Johansson was ringing so well earlier, in terms of any changes, including to just whether it's severity or priority populations in the contract, before we can even get into this, we really have to ask who the community mental health center should serve. And does either of these methods support those policy goals? And we want to support the Department of Health in their conclusion that those discussions and decisions have to be made first before we can get into the weeds on any potential contract changes or what that might look like. So with that, Mr. Chairman, I will stop and pause and stand for any questions you have right now.
Thank you, Andy. Committee, any questions for Ms. Somerville?
Mr. Chairman.
Senator Kinski.
I'm curious, dovetailing off of the prior presentation about a waiver, is it possible to take your existing community centers and restyle them as a waiver program and limiting the waiver payments to the community mental health centers so that we know it's the priority targets that are being served, not opening it up to every provider and they just cherry pick off the easiest to serve patients, but say we're going to create a waiver program which looks 90% like what we've got now and shift 50% of the expense over to the Medicaid program. I hope that makes sense. How tough would that be to do, if you understand my question?
Mr. Chairman, Mr. Co-Chairman, I do understand the question, and it's a question we've been kicking around here for a little while now. And unfortunately, the answer is it's not a simple process. It can be a long process. There's a variety of states that use this system where they have either Medicaid expansion or behavioral health waiver. And so their community mental health system is substantially supported by Medicaid dollars. And they've done that way. There's also a thing out there called a certified community mental health center. So it's a CCMHC program through SAMHSA that provides additional dollars to come in. Unfortunately, we were not in a position, and this was prior to my time, but we were not in a position to apply for the planning grants through SAMHSA for that a few years ago. And we are awaiting with bated breath their return so that we can start to plan and potentially look at those programs as well. Whether we can do behavioral health waiver or there's another way to modify our Medicaid coverage to support our community mental health centers is a question that I have asked both Department of Health and Medicaid, and I hope it's a conversation we can get more in depth into.
Hey, Andy, we had some cutout. Did you say we passed up the opportunity to get SAMHSA planning grants? Did you say we passed that up?
Mr. Chairman, Mr. Co-Chairman, my understanding is this was before my time. This state was not ready to do that. It was not in a position to do that at that time. And so that opportunity was missed a few years ago. And although SAMHSA has released more money for community mental health, or certified community mental health centers, in fact, the last application was, I think, 4 months ago. They've not released any more planning grant money, and there would need to be some planning dollars in that before we could go down that road.
Paul, did you have a comment? See if I can unmute you.
There, is that it?
Yep.
I was involved with that at the national level, at National Council and the Certified Community Behavioral Health Centers. We didn't really pass it up. What happened was the feds came out and said, we're going to do these Certified Community Mental Behavioral Health Centers similar to the community health centers that they did, or the FQHCs. And so then what happened was they only gave it to 8 states. And then the next thing they did is they opened it up a little wider. and only gave it to a few more states. The problem is with the certified behavioral health centers, even if they open it up broadly, the requirements like every certified behavioral health center has to have a medical director. Every certified behavioral health center has to have various things. And so when you get into the more rural populations, it may not be feasible how the federal regulations are looked at. So we're very interested in that because you get enhanced payments. But really, because of the federal stuff, it's just not been feasible.
Thank you. Follow-up question, Senator Kinski? Okay. Any other questions, committee? Sue, please, or Chairman Wilson.
Thank you, Mr. Chairman. This question is kind of broadly for Andy and Paul, really, and I think maybe Stefan has gone off, but and I kind of hate to ask the question because it sounds like really cold-hearted and penny pinching, but if we were, when you have a lot of priorities, then there's no priorities. And if we were to try to say, okay, some people are going to, I don't know if you even can turn people away, but some people are going to not be seen for 60 days or I don't know what. I mean, but are you aware, what I'm aiming at is, are you aware of any research that would give a sense of the return on investment or the expenditure not made when you treating, let's say, a pre or post corrections population or severely mentally ill? In other words, what I'm trying to get at is, even among our priorities, are there some people who, and I don't want to dismiss the pain in their own life, but who if you don't see them right away, have less impact on the community? I mean, are you aware of any kind of research that way other than just sort of anecdotally? Does that make sense?
Mr. Chairman, Chairman Wilson, it makes perfect sense and echoes the discussion we had amongst WAMSNAC directors last week. As far as specific research, there is a lot of material out there. I would have to go back through and pull out some good stuff to send you that kind of ran the gambit. But I do believe that there are some states that have used those models, and I would defer to Paul a little bit in terms of what that might look like, because to be quite honest, it's a real conversation right now in light of budget reductions.
Paul, please.
Mr. Chairman, Representative Wilson, probably the best model to look at that in terms of cost savings and trying to pare down kind of who's in and who's out and where's the most bang for the buck is, if you look at, especially in Missouri, the behavioral health home, where they were trying to figure out for the seriously mentally ill, seriously persistently mentally ill, they were trying to draw down costs. Well, the costs that they drew down, what they knew was, if we get the community mental health system involved, we're not necessarily going to drive the community mental health center system costs down, but we're really going to drive down our other medical costs related to Medicaid. So the majority, not the majority, but a large portion of people we see have related health issues like severe diabetes and I mean, really serious problems. So if what they found was, if those people are involved with community mental health system as their primary driver to get them to appointments and stuff, they drove down these other costs. The other thing I know is that there are some other states, there's a state to the north of us and some other states who, when they had their previous financial issues, decided to not serve some segments, and I'm not talking generally or broadly, but to really whittle it down more. And what they ended up saying was it cost them more headaches and money in the long run because these people were ending up other places. And so really at the end of the day, and I agree with, and I'm a huge fan of the community mental health center, but at the end of the day, you only got so much money, and there's realities, and the tough questions are who's in and who's out, and where do we draw that line? And there's going to be costs to that. But I think that's a discussion with the legislature and the Department of Health and the providers to kind of come together to say what's going to be best there, given the realities of our dollars.
Okay. Representative Wilson, any follow-up? Senator Schuler, I believe you had a hand up.
Thank you, Mr. Chairman. And this was probably for either Mr. Demler or Miss Somerville, whichever one of you can answer it. But the third bullet there, when you talk about contracts being over surface, where does the incentive truly work? I guess I have two questions actually. What type of incentives are in place right now for our community health centers? I mean, does it have to do with recidivism? I'm not sure. And then secondly, are there other incentives that we don't have available that maybe we should be looking at to try and maybe streamline our services and be more efficient and effective? Thank you.
Mr. Chairman.
I'll leave that to you.
Mr. Chairman, Senator Schuler, so the answer, so the first question, what incentives are available in the contracts to community mental health centers? That is the priority populations that were put in the contract. So that was devised, as I understand it, to be an incentive to the community mental health centers to make sure they were really focusing on those populations and really, again, as Mr. Demple mentioned, driving those costs down for the seriously mental ill or youth or kids with serious emotional disturbance. So that's the extent of any incentives that are in the contracts right now. As far as what we can look at, yes, there are a plethora of different models out there in terms of how you can incentivize a system if you want to go that direction. But before you can start to look at incentives, you really have to, again, decide who the system is serving and what type of payment you want to have. But there are options out there.
Thank you.
Okay, thank you. Any other questions? Okay. Thank you. I think we have one other person on there, Elizabeth, Ms. Foland.
Mr. Chairman, yes, we do. And since I made a mistake, I do apologize for that with my mic being live. She's going to be calling in instead of using her computer, so I apologize.
We just hope next time you'll sing us a song. So do we have Ms. Foland on? By phone?
I believe she has been admitted, and I believe she should be able to speak now.
She is. Very good.
I'm here.
Cheryl, we have you on and we can hear you. Please.
Great. Thank you, Mr. Chair, members of the committee. My name is Cheryl Foland. I'm an LCSW in Rawlins, Wyoming. And I wanted to support the funding discussions today. And I find it interesting that, again, we end up back to the discussions of the larger areas and the community mental health centers and their staff. Right now, I'd like to speak to you about just Carbon County. And our community mental health center has 2 licensed providers right now. Within Carbon County alone, there are 5 licensed mental health providers and 1 licensed addictions therapist. We take in, as private practice providers, we do work, I hope, well with our county facility in serving the populations the best we can. I can speak to my client base, which is very similar to the community mental health center. Because they only have 2 licensed providers, oftentimes myself and the other licensed private practice folks are taking in people that they can't serve for a variety of reasons. Mostly is because of conflict of interest. So there may have been someone that the center is seeing a husband or a wife, and we end up with the children, or they're serving the children and we end up with the other family members. The unfortunate part is, unless the providers here are Medicaid providers, approved providers, we end up doing a lot of pro bono work. I wrote off several thousands of dollars last year because there was no funding source available for the clients that I was working with. The other funding base that I have as well is the Department of Family Services. If I have a client who is within a say a neglect case, and I have one of the parents, if that parent does not have Medicaid or private insurance or the ability to pay themselves, then I do receive funding from the Department of Family Services. However, it is at a very low rate. I'm looking now, it's $50 per hour for a mental health session from DFS. Because Carbon County, we are so small and we are spread out, we do try to work together the best we can to meet the needs. Unfortunately, that's extremely difficult with just the few of us practitioners that are in place. We don't necessarily have places to refer our clients. I would also like to add to the discussion, especially on emergency detentions, if I don't have transportation for someone to get to WBI in Casper, my clients or the client that I may see at the hospital is stuck at the hospital until they can be transported. Unfortunately, there's not a lot of reimbursement, as Senator Schuler has recognized in the past discussions on the Labor Committee. I can have a child at the hospital for 3 or 4 days until we can figure out transport, which is usually by ambulance. And Medicaid does not cover that service. Oftentimes, if they're nonviolent, our sheriff's department or police department will transport. Again, that's an unreimbursed expense for our law enforcement agencies. In Carbon County, we only have 2 ambulances. So if we have one ambulance on a transport call, that only leaves one ambulance to deal with the county at large. So the costs that we look at from funding perspectives, a lot of our costs are actually being written off because there is no reimbursement for specific services. We have a multitude of challenges that we try to work through, but we are dependent on the committee for, as our brain trust, to assist us in being able to provide services to our neighbors. And that's exactly where we are in Carbon County. We're helping our neighbors the best we can. Unfortunately, as was brought up earlier, from a pediatric perspective, my options are very, very limited. Right now, Primary Children's in Salt Lake will accept Wyoming Medicaid. I have to go through several steps to get someone placed outside of Wyoming because we don't necessarily have the services. I'm working with a 7-year-old right now. WBI can't take them because of age. I have to then work with Medicaid for pre-approval, which means I have to locate a board-certified pediatric neuropsychologist to do an assessment on my client. And that's just one example of the hurdles and expenses that go into providing those services to our community members. So with that information, I stand for questions.
Thank you. Thank you,
Neuro-
Cheryl. Committee, any questions for Ms. Folan?
On my client.
Okay. Well, I think committee will move on back to Mr. Johansson, and we'll get into this gatekeeping overview, see how far we get here before we take a lunch break. And we may get through his points and then come back for public comment after we have lunch. Stefan, you're on, man.
Thank you, Mr. Chairman and members of the committee. Just to wrap up our section of the presentation, the
Stefan,
committee.
just if I may, just to say, Elizabeth, did you have a question?
Yes, Mr. Chairman, when we swapped, it looked like Representative Olson may have had a question.
Oh, Representative Olson? I apologize, please.
That's all right, Mr. Chairman. I appreciate it. This is perfect because I think my question it's based on the last discussion, but it's really for Stefan, I think. And I'm new to all of this, so please excuse me if our members of health already know the answer to this. But one of the points Cheryl raised was transportation issues. And could you just touch on that a little bit? Is that, I don't know how that works in terms of it not being reimbursed. Is it because of, in her scenario, if you were listening to the testimony that she provided, it sounded like somebody would have been transported from Rollins all the way to Casper. My question is it because of distance? Is it just not reimbursed as a whole? Just give me some insight on what that looks like, why it looks that way. And if we've tried to do something there, we can't, or what can we do? Just help me understand that a little better.
Mr. Chairman, Representative Olson, good question. It is a mixed bag depending on the client, depending on the coverage source, and depending on the situation. So, for example, for adult clients and in the rarer circumstances when an adolescent client is going through the Title 25 process and civilly committed, transportation beyond the first 72 hours of the Title 25 process is provided and can be reimbursed by the Department of Health for the transport of psychiatric patients in civil commitment. That comes through line items in the state hospital's budget. So that's one very specific instance where transportation is provided. On the Medicaid side, Medicaid does reimburse for non-emergency medical transportation. But again, like we talked about this morning, not every client, adolescents included, qualify or are enrolled or eligible for Wyoming Medicaid. So then we move, out of Title 25, out of Medicaid, community mental health or substance abuse centers. There are some funding sources for transportation And I believe what we call quality of life funds can be used to arrange for transportation of clients to appointments, things of that nature. But I think you likely run into, like you alluded to, representative problems of scale, where, do you have the transportation resources to get someone from, the southwest corner of the state to the center of the state all the time? Probably not. So I guess my point, Representative, is we don't have a behavioral health transportation program, so to speak, that arranges for all of these different kinds of scenarios or clients. It really is dependent on the coverage source, the program, and the particular scenario that the client or the individual might be going through. So a frustrating answer, but I would say, again, mixed bag of when, how transportation can be arranged and what the reimbursement protocols are.
Follow up, Representative Olson. Okay. Any other? Let me make sure I sweat past anybody. Okay, Stefan, you're on.
Thank you, Mr. Chairman, members of the committee. I'll wrap up our Department of Health presentation relatively quickly here. The committee asked for an overview of gatekeeping, which now we've moved kind of nicely, I think, in a stair-step fashion through this presentation. We started really wide with kind of a statewide look at the funding and some of the populations and the service provision. Then we narrowed it just to the community mental health and substance abuse system to go over for an overview. And now we're talking about even more specific, located in the Title 25 statute, of what's known as gatekeeping. And so the slide that you see on the screen and is number 19 in your packet gives you a very, very brief overview of where this gatekeeping concept came from. It actually grew out of a previous statutory language that was called a single point of responsibility. And it's largely still how it's defined in statute. But going back to 2016, several years ago, when the Title 25 subcommittee was formed, this was one of the major changes to statute that took place. So I'll just mention a few of them, and then we'll get into some of the duties or the statutory intent as we see it from the department of what gatekeeping is. Before I go there, for members of the committee, just want to give you just a quick couple of minute overview of Title 25. You're probably largely aware of it, but this is the legal system and the statutory system by which folks with mental illness or behavioral health issues, as defined by statute, can be civilly committed, involuntarily hospitalized to the Wyoming State Hospital or other providers. Again, I want to stress that this is a legal system, and it's often confused with treatment modalities and service provision, where this is strictly when someone is manifesting behaviors or symptoms that make them dangerous to themselves or others. Various entities in the community, starting at the county level, can start the process of emergency detention and involuntary hospitalization, and that's found in Title 25, Chapter 10. So this gatekeeping idea is a small subsection of that statute that grew out of the Title 25 subcommittee from several years ago. And essentially what it did was it allowed the department to designate what's known as a Title 25 gatekeeper. And some of the duties outlined in that statute, which you can see there is 2510-112G. The gatekeeper that's designated by the department is largely tasked with providing guidance on issues of detention and involuntary treatment, monitoring and coordinating timely, efficient, and effective patient treatment. These are all directly pulled from the statute, and doing this guidance, monitoring, and coordination prior to, during, and after emergency detention or involuntary treatment. So what this really speaks to, or I think spoke to in the statute, was the need for some sort of point of responsibility to not only guide patients who might be going through this process, but really be somewhat of a behavioral health resource expert or coordinator for the courts, for the attorneys that are involved, for the clients themselves, to look at what resources might be available, in some cases as an alternative to hospitalization, but also services that either before or after the actual civil commitment to a hospital setting might benefit the patient. So again, in the language of the statute, and just remembering back to my days working with the Title 25 subcommittee, and several members who are on this committee now were part of those discussions, it was really intended for almost as a case manager, for lack of a better term, but again, someone or an entity that would make recommendations to courts on the best way to serve a client going through this legal system. And often that meant recommending alternative resources, like I mentioned, that could be used, community resources, services, et cetera. Some of the things you all have brought up, like transportation, medication, and pharmacy access was a big point of discussion when this was being developed, of things that could potentially limit someone's need or an individual's need to be, have their rights taken away through civil commitment and be treated in a hospital setting. That really was the point of gatekeeping. But again, no slight on any community or any provider that's been designated by the department to do this. We do have quite a wide variation across the state in what gatekeeping is and what it means. And a lot of that is a function of, like we've been talking about, communities do have different needs, different populations, smaller, larger populations. And I think that standardization for a system like this, especially with Title 25 and the relatively low volume of patients that we see in this system, especially those that escalate higher into the civil commitment process, it would be hard to imagine that the community of Lusk would have the same kind of gatekeeper as the community of Casper, for example. It's just a very different landscape of need. Your last slide number 20 on gatekeeping, just gives you a sense of, since that statute change, kind of what we have currently when it comes to designated gatekeepers. So right now we have 12 Title 25 gatekeepers around the state. Some of those, it seems low when we have 23 counties, but some of these serve multiple counties. For example, Peak Wellness is the designated gatekeeper in the Southeast region, and their catchment area is 3, if not 4 counties. So there's some overlap with some of our gatekeepers. We do have gatekeeper services defined through contract, but like I mentioned, the provision of those services varies by county, by need. The majority, if not all, I'll have to double check that, the majority of these gatekeeper designations and contracts are with community mental health centers. And that was intentional on the part of the department, and I think the Title 25 subcommittee from years ago, again, to as much as we can inject what we know is the purpose and the bedrock of community mental health centers, to wrap around people in the community, to keep them out of higher levels of care, help them maintain and also improve their lives in the community. So the vast majority of these have been with community mental health centers, and those services, like I mentioned, are they vary and are vary by county and by need. So for example, in the early days of this change, 2017-ish, 2018, we had some money that was allocated both with state funds and federal funds of what we called gatekeeper incentive grants. And that was to get community mental health centers and others, again, kind of injected into this Title 25 process more than we had seen in the past. And those of you might remember, part of this was due to a bit of a problem we were seeing in volume and cost in the Title 25 system. A lot of civil commitments in that era from a few select, about 4 counties, were really seeing higher volume in Title 25, and thus the state and the Department of Health were running into quite a big budget deficit. So the point was, can we inject some community resources to try to curb some of the utilization in Title 25. And some of the communities use those incentive grants to, for example, outfit a vehicle to transport Title 25 clients to various services or levels of care. Others hired a staff person, for example, to work in the emergency room when someone needs to be transported to a psychiatric hospital, but they're on the wait list, and so they're sitting in a general hospital and might need to have someone checking in on them more frequently because there could be a self-injury or even a suicide risk. So the services and those incentive grants really varied by community. Going forward, after July 1st of this year, those gatekeeper services are going to be incorporated into the larger contracts that we talked about before. So there will be some standardization of the gatekeeping requirements. But just to give the committee a sense of how we do these gatekeeper designations, we reach out to the county commission in a community to essentially let them know we intend on designating this provider as your Title 25 gatekeeper. And we kind of have a back and forth with the county commission if that's an issue or if there's other recommendations. There's nothing in statute that specifically says this has to be a community mental health center. So we have worked with counties in the past who wanted to go in a different direction, maybe have a third party provider do these services. And we've worked with counties to do that as well. So like I said, it's a mixed bag, but the real intent of this statute was to have sort of a point of responsibility to manage not only the patient, but make recommendations on the resources to courts and to the various entities involved at this really highest level of care in many cases in the behavioral health continuum, which is often triggered by Title 25, which commits people to either a psychiatric hospital or the Wyoming State Hospital. So, Mr. Chairman, that's a really down and dirty overview of the gatekeeping statutes. But again, like we talked about before, it kind of represents a microcosm of the previous topic, which was a microcosm of the previous topic. So hopefully it flowed relatively well, but happy to stand for any questions about gatekeeping, since the information on your slides was very general.
I think, committee, it is 12:56. I think that we're in a good position because I think the questions that might be coming to Stefan to answer and public comment could take a little bit of time. I think we'll go ahead and break for lunch and come back at 1 o'clock. And Stefan will be ready to ask you questions at that time. So please mute and stop your video.
And Chairman Larson, just for those who may be observing on the live stream, we will have a new PM link for them to go ahead and use. This link will not be live.
Very good. Thank you.